We are on live, sir.
Okay. Good evening, delegates and participants, and all our guests who are joined today for this session. And this session is sponsored by FOGSI Young Talent Promotion Committee with Agra and Siliguri Obstetric and Gynecology Societies and West UP ISOPARB. And today this webinar will be about the infertility updates. So before we start with our session, let me give an introduction of our three respective MOCs, Dr. Bhavini Shah, Dr. Ashwini Mohandas, and Dr. Monisha Singh. So let me introduce Dr. Bhavini Shah Balakrishnan. Ma'am is Director of MOMAS Clinic and Consultant Gynecologist and Obstetrician. Ma'am is also MOGS UA Lead of 2020-21. And ma'am was awarded by Dr. Khurshid and Shunu Sheriar Award by MOGS twice in year 2019 and 20. And ma'am has also received Wonder Function Award by FOGSI in November 2019 and MOGS Youth Council member since 2013. And Dr. Monisha Singh, ma'am is currently doing ICOG course under Rainbow Hospitality in Agra, and ma'am is active member of Young Talent Promotion Committee 2020-2023. And Dr. Ashwini Mohandas, ma'am is consultant gynecologist at Tej Memorial Hospital, UP, and currently pursuing fellowship in reproductive medicine at Rainbow Hospital, Agra. And ma'am has also presented various papers on high-risk obstetrics and medico-legal POSCO cases under the guidance of Dr. Ashok Anand, HOD of JJ Hospital. So I will hand over the session to Dr. Ashwini Mohandas. Ma'am, we welcome you on our platform, and I will hand over the session. Thank you, ma'am.
Thank you so much. Thank you so much. And a very, very, very warm welcome to one and all for our today's webinar on infertility update. This session is one of its kind where the leading organizations of FOGSI, YTP Committee, Agra and Siliguri OBGYN societies and West UP ISOPARB have all come together to discuss the updates on infertility. Infertility as such is an emotional roller coaster, not just for the person suffering, but also for us as doctors treating. And we are positive that with this webinar, we do not leave even the tiniest bit of hope in helping the patients with fertility issues. Keeping this in mind, we hope that the session covers all the latest updates on the diverse brewing topics that we have related to infertility. And we are really excited to get this 2-hour jam-packed session up and going. Let me just say that the response to this webinar has been really overwhelming, and we have registered more than 200 docs across the country who are currently watching us. So without further ado, I would first like to introduce our very own sweet, humble, ever-shining chairperson of FOGSI YTP Committee, Dr. Niharika ma'am. Can we please have a CV?
Thank you so much, Ashwini. And it gives me great pleasure to welcome everyone here for the YTP webinar on infertility update. As you all know, Young Talent Promotion Committee has conducted over more than 80 webinars and now 15 physical meetings in this year. And we have been going really strong with my team of youth over India under 40. As when I became the chairperson for Young Talent Promotion Committee, our aim was to trigger transformation, and that's what we have done. We have 40 new YUVA members in my committee who are under 40 and from all 4 zones of FOGSI. Our aim is to follow work with perseverance and with leaders giving us blessings all throughout our tenure. I am so grateful to have this opportunity to also welcome today Dr. Rishikesh Pai sir, who's been my mentor, Dr. Rajendra Pardesi sir, Dr. Madhuri Patel, Dr. Archana Verma madam, who has always been supportive towards me. Also, our President Shanta Kumari madam, who's been the guiding force behind my committee. With these words, I would now invite our President-elect of FOGSI, and it gives me great pleasure to say that, sir. Of course,
don't have to introduce everything, Niharika, a little bit.
Sir, I am going to just say from my heart that you've been the mentor for all our youth, and you have actually brought so many youngsters into the organization and have given actually wings to youth. And I am so grateful that you've been a father figure throughout my journey in FOGSI. It's been a small, short journey, and I'm still learning under you, and I would still go on learning and following you. We welcome you here, sir.
Thank you for inviting me, Niharika. You have done a fantastic job as the chairman of the Young Talent Promotion Committee. It's a, I think even presidents of FOGSI may sweat to do such kind of work, doing 80 webinars and, on ground work and all fantastic work. And I'm sure you have a great future to go. See, IVF is now in the, transition. Like when I started, I was, I think 29 years old when I went to do my fellowship in Australia. That time there was no backing as such. I just wrote to many people and, I got 3-4 answers to come there, and I borrowed money from my father and went there. And when I came back also, I had no money. So my father was good enough to give me a loan of 6 lakh rupees and we started the IVF center at Pearl Center. Today, I've just bought 2 embryos for 2.5 crore rupees. So it doesn't. So what I'm saying is that, yes, it has been a fantastic journey of nearly 30 years. And in this 30 years, there were a lot of us, all of us in the early phase were there. And now we are in the next phase because the ART bill has come. So, but then there is a huge amount of people. So we have got 1.3 billion people. So I feel that we have touched a little iceberg. 200,000, nearly 3 to 6 million people need IVF in India. So there's a huge gap to be filled, but we'll have to decrease our charges. You understand? When you decrease the charges, you have to, I believe, I'm a philosophy of not compromising on the care. It's not fair to offer a substandard care to people just because they are not well off. The challenge is to offer the same care which you would give an affluent person and achieve a grade. So if you can give an IVF cycle at 70,000, you should not compromise the care on it. You understand? So it's very important to keep that in mind. And the only way that can be done is by sacrificing yourself in the process. So I feel that there are 3 types of CSRs. One is what is known as, the CSR, which is there, which we call corporate CSR, corporate social responsibility. That is a CSR. The second CSR is the community CSR. And the third CSR, which is very important for all of us to implement, and that is the ISR, I call it, individual social responsibility. So individual social responsibility is very important. And, like when I started our medical career, we never thought that we'll make this kind of money. Frankly, we never thought. My father used to earn 2,000 rupees pay. So I never thought. As we evolved in the last 30 years, the doctors started making money. So it was never a money-oriented profession. Now, so you must remember to always enjoy the journey of life. Don't go after the goal too aggressively. The second thing is that don't do everything too early. Because the longevities are going up a lot. There's a writer called Yuval Moses who has said that our longevity will go to 150 years. So if suppose many people will get married at the age of, remarried at the age of 75 again and have children at the age of 80. So in this kind of scenario, you need to pace your life. You can't do everything in a quick way. Then what do you do after everything is over? So you need to enjoy the journey. You need to savor the journey and pace your life so that you have a good, enjoyable innings. And suddenly, otherwise, you will be, hurry, what do I do now? Everything is over. I've done this, I've done this, I've done this. What do I do next? And the other thing I would like to say, when in my life, my dad, in the last 10 years, he deviated. He changed his profession. He went into naturopathy, but he was very unhappy. So I personally feel, when I look at the doyens like B.N. Chakravarti or Daftari, what I learned from them is that if you want to be happy, don't deviate from your goal. If you are a gynecologist, keep on doing that till the end, because there is more happiness in that kind of target trajectory rather than deviation into other things. Because deviation is very difficult to achieve in a short span of time. Anyway, Dr. Rajendra Singh is there, Dr. Bassapa is there, all of you youngsters are there. You can see Dr. Asha Jain also there, and many of my friends are there. So I'll not take much of your time. And one last thing I would like to tell you, the ART bill has a little bit softer now, and we must appreciate our President, Dr. Prakash Trivedi of ISAR, who did a lot of work for us, and Prakash Trivedi and his team did a great amount of work, and he has, so the ISAR or all our organizations, FOGSI, even Shanta Kumari, all of our organizations are important for us. So you must see that you stay with the organizations and build the organization. And those who are not members of our organization, you must bring them into the fold of our organization. I feel nearly 25%, means we have about 30-40,000 is my estimate. Gynecologists are not members of FOGSI. So one of the important things for ISAR and FOGSI is to increase our membership and strengthen our organization. More we are together, more collectivism we have together, better we will have power in society. People will listen to us if we have the numbers with us. I would like to thank you again for inviting me for this function. Thank you.
Thank you so much, sir. And actually, your words are truly an inspiration. And it's like slow, steady steps forward. And that's what we're going to do with you. And it's always such a pleasure to hear you when you actually keep inspiring all of us to do good in the society. And that's what we try and do. We also have with us here today Dr. Rajendra Singh Pardesi and Dr. Archana Verma ma'am. And I would invite Rajendra sir, who has been now...
I sorry, I forgot to mention Archana Verma ji. I couldn't see her in the plane. So sorry about that. And even Dr. Sita has joined us. So many people keep on joining. So I just acknowledge them and apologize if I missed out on anyone. Thank you.
Thank you, sir. So Rajendra sir has been now elected president of FOGSI, and the heartiest congratulations to Rajendra sir, who's been here with us.
It's okay, Niharika.
Yes, sir.
Good afternoon, everybody. Respected Dr. Rishikesh Pai sir, Dr. Madhuri Patel, Dr. Archana Verma, and office bearers, and all stalwarts of FOGSI. So I'm feeling proud to be a part of this FOGSI webinar on infertility, and mainly why? Because it's organized by YTP, our young committee, YTP committee with West UP, ISOPARB, Siliguri and Agra. First, I wish to congratulate Dr. Niharika Malhotra and Dr. Priyanka Roy for organizing such an academic feast on infertility. As Dr. Rishikesh told, it's a really important topic in future also. And it's a fraternity, it's not only a topic, but it's a fraternity. I wish every success to Dr. Niharika for her future endeavor in FOGSI. So with the galaxy of speakers like Dr. Kalyani, Dr. Parikshit, Sheetal, Dr. Veronica, Dr. Akruti, Dr. Jadeja, Chaitanya, Aditi, Amruta, and FOGSI stalwart, as I told you, Dr. Sita Pal, Charmila, Dr. Pratik Tambe, Dr. Asha, Dr. Kalpana, Dr. Rituparna, Shobha Arora, Ruchika Garg, Himanshu Roy, Aarti, Dr. Savita, and the responsibility shouldering with the youth, Dr. Bhavini, Dr. Monisha, and Dr. Ashwini. Ashwini Mohandas is very active. She rang up me twice, thrice. Sir, please join. Please do this. She is very active, and she is a sign of activeness of your YTP committee, Young Talent Promotion. So I don't want to be in between you and scientific content. I wish every success to this webinar. Thank you. Thank you so much. Thank you.
Thank you so much, sir.
Thank you, sir.
We are so grateful that you could join us and bless our program today. We are now shifting towards physical meetings, and I thought that we are going to continue at least few webinars throughout the year to keep in touch with everyone. And that's how we are going to limit ourselves to offline and online meets. It also gives me great pleasure to have my mentor, Archana Verma madam here, and I started working under her committee as of public awareness, where I understood how committees actually work and what is it to bring people in together to take them ahead. And that's how I learned. And I think that's why YTP committee does so well, because it's because of Archana madam who has actually guided me. And I welcome you here, Archana ma'am, and we would like to have a few words from you.
Thank you.
Ma'am?
Ma'am, it's not audible.
I think ma'am is having a little bit of technical
Connection.
difficulties. Can you talk to her, Chitra, till we go ahead?
Yes, ma'am.
We also welcome Basab sir here. He is the Vice President in charge of the YTP committee, and he's been behind my back guiding me throughout all my programs. And whenever I land into trouble, he's the go-to person. And Basab sir, few words from you, because we are now going to stick to physical meetings, and I think I'll miss you often in all my programs.
Yeah, thanks, Niharika. I think also, yeah, we won't be able to connect for all physical programs, of course, but this was what was expected. As you rightly said, the webinars will continue. There will be a fair amount of online academia throughout the year. And there will be the physical stuff for people to connect to for the fellowship, for the camaraderie, which will always be there. So there will be a perfect balance we expect in the years to come, as this will be the trend. So wonderful program with a combination of FOGSI and ISOPARB and societies, Agra and Siliguri connecting, that's north and east. So really wonderful. It's a nice bundle that you've got, and your program is very well laid out. Wonderful speakers, wonderful faculty. So nothing to say about that, Niharika. You've done wonderful work throughout your tenure, and this is no different. So look forward for wonderful academia and wish you all the best, as Pardeshi sir has said. So that's wishing you all the best. And Rishi, the golden words are always very nice to hear all the time. So that's wonderful. Thank you.
Thank you so much, Basab sir. And over to Ashwini and Monisha now to take over, and let's begin our academic session. Whenever Archana madam joins us, we'll have our blessings.
Join,
I think
yes, ma'am. Archana ma'am is here. Yes, ma'am.
Yeah, actually, Niharika, yes, there's a lot of issue in Wi-Fi, and my best wishes with you. And Dr. Pai is enumerated wonderfully. Just remember that individual, that responsibility, that is the Maha Mantra for everything. I think he's a great leader, and we should, if we just get 1% of that's his intelligence into our head, we will be much better. So, Dr. Pardeshi sir, thank you very much, and all Dr. Basab, Niharika, you've done wonderful work, and congratulations. And yeah.
Thank you so much, ma'am. Thank you, Monisha. Let's begin our.
Thank you so much, ma'am. Thank you to all the guest of honors and of course our chief guest. And before we begin, I would just like to start with a small prayer to introduce with our session. Chitra, can you...
Kurutvam kalyanam arogyam dhanasampadam shubham kurutvam kalyanam arogyam dhanasampadam shatrubuddhi vinashaya deepajyotirnamostute deepajyotirnamostute shubham kurutvam kalyanam arogyam dhanasampadam Shubham kurutvam kalyanam arogyam.
Thank you so much. Let's, without further ado, let's begin our session 1 on PCOS and IUI. And it gives me immense pleasure to welcome our chairperson for this session, Dr. Aarti ma'am. Aarti ma'am is the chairperson of Indian Menopause Society and the president of Agra Obstetric and Gynecology Society. She is the founder and the head of Sat Society and has received multiple awards nationally and also received the Golden Aim Award as well as the Samaj Ratna Award in her field. Ma'am, it gives me immense pleasure to invite you for our first session, and I would like you, ma'am, to please introduce our speaker of the session, Dr. Kalyani ma'am.
Thank you so much. Dr. Kalyani Shrimali, she is the speaker. Now she will speak on PCOS and IUI. And Dr. Kalyani Shrimali is the senior consultant reproductive medicine at Nova IVF Indore. She has received formal training in the field of reproductive medicine from so many institutes, Masters in Reproductive Medicine, NHS London, Germany, Mumbai, and from so many institutes. She is a dedicated infertility specialist with an experience of almost 11 years, has been the awardee of MOGS Shantabai Gulabchand Traveling Fellowship Award and recently been awarded with FOGSI Vasanta Ben Award for 2016 and 17. Currently, she is a member of FOGSI Endocrinology and YTP Committee and executive member of MPSA. Welcome, Dr. Kalyani. I welcome you for your lecture.
Thank you so much, Aarti ma'am. And thank you all the esteemed people who are here, all my seniors. Thank you, Niharika, for involving me in this program. Thank you, Priyankur, for constantly being behind me for, reminder and to come in for this program. As it sounds, I'm a little bit of nervous because of so many seniors out here and I being the opening batsman. So I guess, yes, but nevertheless, we will start with the topic for today. I would just like to share my screen and just let me know if you people can see it.
Okay.
Can you?
Yes, ma'am.
All right. So the topic given today are two different subgroups. One is the PCO and the other is an IUI. So both topic in itself is quite a vast topic, but I will try to cover or I'll try to ponder over the points which are the most important, starting from PCOs and how do we end up in an IUI or stimulating that patient of PCOs for the IUI. 1 second, something going wrong. Yeah, so as we all know, PCOS is not merely a reproductive disorder, but an endocrinological disorder affecting the women in the reproductive years. Although hyperandrogenism and infertility that PCOS causes are distressing to the young woman, its metabolic sequelae eventually plague the individual in terms of morbidity and mortality. I don't know, something going wrong. 1 second. Okay, as we all know, it is the most commonest reproductive disease that endocrine disorder that we have seen in the reproductive age group, almost 8 to 11%, out of which anovulatory infertility is almost 70 to 80%. Indians have amongst the highest prevalence rates in the world, almost 41% in the reproductive group. I don't know why this is happening, but it's skipping 4-5 slides at a time.
And once share it again, ma'am.
Should I share it?
I think so. There is a timer, ma'am. We need to remove that.
Timer?
Yes, ma'am.
Okay, how do I do that? 1 second. Sorry.
No issues, ma'am.
So I've just gone on the slide.
Don't worry. Sometimes IUI takes time to prepare the sample.
Also, something going wrong with my slides only. I have been on the slide share, on the slideshow, but I don't know, somehow it's going wrong.
Don't put it on slideshow, Kalyani. Just move up and down.
Don't put on slideshow.
Yeah.
Hello, boss. Namaskar, Dr. Pai.
हाँ डॉक्टर राहुल आपको देख रहा हूँ मैं.
क्या करूँ इससे busy time हो गई. Hi, Niharika.
Yes, just go like that. That's okay.
Okay, coming to the definition of PCOS, I think we all know there are multiple definitions according to multiple committees which are there. So there's no universally accepted definition for PCOS. When we started with the PCOS, the first definition came on around in 1990 with the NIH consensus. Then we came to the sonographic guidance of the polycystic ovaries, and first we defined it as 12 or more follicles. But now with the newer generation of the ultrasonography machines, what we have seen that we need to have at least more than 25 or more follicles measuring up to 2 to 9 millimeter in diameter, or the volume of the ovary more than 10 ml. In 2003, ESHRE ASRM, the Rotterdam criteria came in, which requires presence of 2 out of the following 3 criteria: the oligoanovulation, hyperandrogenism, or polycystic ovaries. Coming to the biochemical and the diagnostic markers, we all know that there has to be elevated androgen levels, that is total testosterone more than 60 or free testosterone of more than 0.75, elevated LH-FSH ratio of more than 2:1, increased insulin levels, insulin resistance, which we more focus on, but lab diagnosis of insulin resistance is not necessary, and most of the times we don't see it, and of course the ultrasound appearance of the PCOS. The fertility treatment in patients of PCOS, of course, there are multiple ovulation induction drugs which are available, but now we are going to talk today about the IUI. So we are going to learn about how we are going to induce this patient of PCO for the IUI. So if we understand about the PCO, we all know that if there's 100% patients with PCOS, 30% will need nothing. They will spontaneously conceive, but 70%, which is a huge population, will still end up coming to the doctors and probably will need to put them on some medical support or procedures like IUI or IVF. Ovulation induction in IUI. So the steps in a PCO patient, what we need to see is minimal stimulation of ovaries. We can't end up having hyperstimulation. We need to properly monitor them. So monitoring is the key to any IUI or any patient of PCO. So follicular study, trigger it with HCG or GnRH agonist that we need to take a decision. IUI, depending upon the semen analysis, husband or donor. Progesterone for the luteal phase supplementation is must. And UPT or beta HCG after 14 days. So this would be a step for any patient of PCOS coming for an IUI. So coming to the IUI in general, what will be the contraindications? Absolute will be the bilateral tubal blocks or hydrosalpinx. Genital tract infection, stage 3, stage 4 endometriosis. Relative would be genetic abnormality in the husband, women aged more than 38, more than 6 IUI already done, and pathologies like septic uterus, polyps, or fibroids. In women with PCOS who are anovulatory, to give metformin or inositol for minimum of 2 to 3 months is recommended. Extended dose letrozole protocol is something which has come up new in the market and has given very good, excellent results. Avoid clomiphene citrate, low dose step up or step down protocol with RFSH, and try to develop only 1 or 2 eggs. Antagonist usage in IUI stimulation is something we can consider in cases of PCOS where we are expecting a premature LH rise. In the stimulation protocols, we all know the ovulogens, clomiphene citrate, letrozole, combination of clomiphene or letrozole with gonadotropins alone, agonists with the gonadotropins, and antagonists with the gonadotropins. Coming to the oral drugs, I don't need to go into details. We all know clomiphene citrate, it's a wonderful fertility drug. Selective estrogen receptor modulator, mode of action is to increase the pituitary LH and FSH to promote the follicular growth. Clomiphene induces the follicle growth and it does not cause ovulation. So we all need to keep in mind, CC is used only for the follicular growth. The follicle which induces the ovulation through a positive estrogen feedback, which induces a surge in LH, that leads to ovulation. Always start with a lower dose in case if you're planning for a patient who is a lean PCO. So BMI is the most important when we are deciding upon the clomiphene dosage. Do not persist with an anovulatory dose. Increasing a satisfactory dose does not help. Most ovulation occurs up to a dose of 150 milligram for 5 days. Anti-estrogenic, we all know, so it reduces the implantation rate due to thin endometrium. Traditionally, day 5 to 9 is established in 1960, so doctors could monitor with daily pelvic examination. But now we also start on day 2 to day 6. And the best part about the clomiphene is you can even start later in the cycle and the follicular phase, that's from day 5 or day 6. Coming to the letrozole, so in aromatase inhibitors, we have got 2 subgroups, that's letrozole and anastrozole. The most commonly used is the letrozole. It blocks the conversion of the androstenedione to estrogens used for the treatment of breast cancer in postmenopausal women. The dosage recommended is 2.5 to 5 milligram per day, and now we have the extended dose also. It does not block the estrogen receptor, which is the most advantageous part of it, so no detrimental effect on the endometrium or cervical mucus. Negative feedback mechanism not turned off, less chances of multiple follicular development, and this is exactly what we want in a PCO patient, monofollicular genesis. Coming to the gonadotropins, we have the low dose step-up protocol. In the low dose step-up protocol, you start with a dose of 37.5 to 75 IU per day, depending again upon the age of the patient and the BMI. Step up by 37.5 to 50, no dominant follicle more than 10 millimeters seen after 7 days. Again, step up after 7 days if you see there's no growth in the follicle, till the follicle reaches the size of 18 millimeter with the endometrium thickness of 7 millimeter. Of course, after that, you decide on the trigger for that patient and plan your IUI. In the step down protocol, the starting dose will be a little on the higher side. Maybe you start with 150 IU for 7 days. Again, you can reduce it to 100, reduce to 50 till the optimal follicular growth and then trigger an IUI. This is something which we don't routinely use, but routinely what we use is the low dose step up protocol. Antagonist, this is something which is very controversial. Why? Because in an IUI cycle, we are trying to make it as much as cost effective for the patient in an IUI. So we try to limit our usage of the recombinant FSH or the gonadotropins, and to combine with an antagonist is going to add to the pocket of the patient. So yes, but in certain patients where we are seeing that, there's a premature LH surge, or certain patients where we are seeing premature rupture, in those patients, we can add up with the antagonist in IUI. Impact of GnRH antagonist addition to pregnancy cycle rates in GnRH in gonadotropin stimulated IUI cycle. They have said that there's no significant difference in the clinical pregnancy rate. This study was published in Human Reproductive Science in 2016. There was one more study which was published in the Taiwan Journal of Obs and Gynae in 2019, which had patient number of 175 IUIs in PCO patients. LH and progesterone levels are much lower in the intact group. Premature LH surge was also significantly lower in the study group, and pregnancy rates were higher in the study group. However, statistically, it was not significant. Coming back to when we have used so much of gonadotropins, antagonist and all, so how are we going to monitor this patient? And why do we need to monitor such patients? Why? One is to evaluate if the dose being used is optimal. The second, to adjust any dose, like we discussed about the low dose step up, that we need to do the scan, do the estradiol level to decide if we need to increase the gonadotropins. To find the optimal time for inducing the ovulation, that's the trigger time, to time the IUI, and the most important in PCO is to avoid excessive stimulation, to prevent OHSS and multiple pregnancy. And of course, to guide the patient in case if she's ending up in OHSS, whether it's a good cycle for her to get converted into an IVF or not. And how are we going to monitor? So the most common is try to minimize the cost effectiveness for the patient. So either we just do an ultrasonography and try to monitor it. So if you're doing it by yourself and not dependent on the radiologist, I think ultrasound would be the number one step to monitor the patient undergoing the stimulation with gonadotropins. Of course, you can combine with the hormonal levels of estrogen, or you can do a color power Doppler, or by any other hormones like LH rise and all, you can monitor the patient. So like I discussed, sonography is the mainstay of monitoring. Baseline scan before the starting of the stimulation is very important, because certain patients may have a follicular cyst or a simple cyst on day 2, day 3, which we may, get confused on day 7 or day 8 has a follicle which has developed very early. Start stimulation after 5 days, start monitoring after 5 days of stimulation. Accurate measurement of the follicular number, size, and endometrial thickness is very important. Estradiol levels, normally it's recommended only in the gonadotropin cycles, where we are trying to monitor whether there's a growth of the follicle happening or not, and whether if it is it ending up in an OHSS or not. So ideal rise should be 30 to 50% per day. Clinics providing ovarian stimulation with gonadotropins should have protocols in place for preventing, diagnosis, and managing OHSS. This is very important to all the people out there listening to us, that when we are talking about gonadotropins, you actually need to have the provision for OHSS, or you need to have an access to an IVF center or a fertility specialist who can manage an OHSS. Coming to the trigger part in the IUI, the most important, there are multiple triggers which are available now. We all know there's HCG, the standardized urinary HCG, recombinant HCG, GnRH agonist. Nowadays, we are using a lot of dual triggers. And of course, if it's a natural cycle or the patient doesn't want to take the trigger and you want to plan a natural LH search by LH kits, that is also available. So a study done by Zhuanghua in 2019 said that the effect of 3 triggers on the pregnancy outcome of IUI, it suggested that all the 3 methods, whichever you use, the HCG, agonist, dual, could induce ovulation. Their effects on the IUI clinical pregnancy rate outcomes were similar. But in all, the commonest what we use is the HCG, because HCG works in both the ways. It causes the induction of the ovulation as well as it helps as a good luteal support. So there's this interesting study published in Reproductive Biomed in 2019 for the IUI with the trigger. So this study basically said, it's a randomized clinical trial, multicentric RCT done at the 7 Dutch centers, that the CPR after 4 cycles were 26.2% for simultaneous IUI. Simultaneous IUI means, okay, we gave the trigger today and we did the IUI also today. And the standard IUI, what we do is usually after 36 hours of giving the trigger. So if we look into this comparison between both the groups, so 4 cycles, that's first IUI, second IUI, third IUI, and fourth IUI. So in the group where we had done the trigger with the simultaneous IUI, it was almost 26.2%. and it was 33.7% for regular IUI. The CPR per cycle in the simultaneous IUI group was 6.8%, 10.5, 9.5, and 7.5 for the first, second, and third. In the standard regular IUI group, it was 8.3, 16.4, 13.5. So if you see the IUI, there was a similar rates of the clinical pregnancy rate between both the groups. When to trigger? This is very important because sometimes we get confused whether 16 mm is the right size, 18 mm is the right size, 20 mm is the right size. So this was a study which was done in November 2020, published in Fertile Study, which was a retrospective cohort study. Total of 1,676 cycles were included, which showed a clinical pregnancy rate of 13.8%. The highest CPR was seen when the lead follicle was 21 to 22 mm. So this concluded that HCG administration at 21 to 22 millimeter is associated with higher odds of clinical pregnancy in patients undergoing CC cycles. When we talk about gonadotropins, 17 to 19 mm or let's say 18 mm is the ideal size when we should be triggering. But this is very important because most of the gynecologists, they use as the CC or the letrozole when they're triggering. So to understand which is the correct time of trigger is very important to plan the IUI. Single versus double IUI, we all know it adds to the cost of the patient. But yes, if the patient doesn't want to end up doing an IVF cycle and we want to increase the chances of the patient conceiving, the Cochrane review said that a second IUI in the same cycle can be done, and double IUI resulted in a significant benefit over the single IUI in the treatment of subfertile couples. Does the time interval between semen collection, processing, and insemination affects the results of IUI? So this was the topic which was published by Dr. Gautam Alabadia in the Journal of Obs and Gynae in 2009, which mentioned that the semen specimens be collected at the clinic and processed as soon as just after the liquefaction and within 30 minutes of the collection. IUI should be performed as soon as within 90 minutes of semen collection. But then one more study came in 2017 by Fertile and Study, was published in Fertile and Study by Janssen, which said that longer time interval between semen processing and IUI does not affect the pregnancy outcome. IUI done the day after in 24 hours of semen collection and processing. IUI done immediately after sperm collection and processing. So if we compare these two groups, in the first group, we had 77 of 547 couples on ongoing pregnancy in the delayed IUI, and almost 13% ongoing pregnancy in the immediate IUI. So there is no negative effect on the pregnancy rate when IUI of the processed sperm is delayed until the next day. This approach allows additional flexibility for the couples when the male partner is not available on the day of the ovulation, and it allows for a spread of workload in the lab. I don't know about this because this is just the study which I came across when I was making this presentation, but this was something which was interesting, and I thought it's an open to discussion whether we should be delaying the IUI or is it very much necessary that we should be finishing the IUI of the processed sperms in 90 minutes. Soft versus firm catheters, no evidence of a significant effect different regarding the choice of the catheter, but of course the pain is less when we are using a softer catheter. Procedure, we all know the most important thing that we need to keep in mind is to reduce the volume of the semen sample to 0.3 to 0.5 ml. In our setup, we use is usually the 0.5 ml of the processed semen sample. Progesterone, most important thing we need to discuss about. So this was a study which was published in 2017 and Fertile and studied by Green KA, which the topic was the progesterone uterus support after ovulation induction and IUI. So it was a systematic review and meta-analysis. 11 trials were identified that met inclusion criteria and constituted 2,842 patients undergoing 4,065 cycles. So it mentioned that progesterone LPS is beneficial to the patients undergoing OI with gonadotropin IUI cycles, and it did not benefit the patients undergoing with CC or CC plus gonadotropins. Comparison of the oral dydrogesterone and vaginal micronized progesterone. Because nowadays we have so many oral formulations available for progesterone, so it's very important for us to understand whether vaginal micronized is still the choice or whether we can shift to the oral. So according to this study, oral dydrogesterone and vaginal micronized progesterone provided similar pregnancy outcomes in terms of CPR and LVR in women undergoing IUI in conjunction with the ovarian stimulation with RFSH. Success rate, we all know only IUI without any stimulation is 2 to 4%, CC plus IUI is 8 to 10%. When we add up the gonadotropins, almost 14 to 16%. And when you time it properly and with a good setup your IUI success rate may increase from 15 to 20%. Side effects, usually they are negligible, but some patients may experience pain, bleeding, or some form of infection. Thank you.
Thank you so much, ma'am, for that wonderful session. And you actually covered all the topics to the point related to this. And it would be amazing if Dr. Aarti ma'am, our chairperson, could share some inputs on this, ma'am.
Kalyani, it's a very beautiful presentation. You have covered each and everything regarding the IUI and stimulation. And the most important thing in the PCOS patient to keep in attention is the hyperstimulation. Okay, we have to do it whenever we are doing with the gonadotropins. We should do with the smaller dose, and we should always keep in our mind even without using the gonadotropins, patient may go to the hyperstimulation of the PCOS, and even with the general treatment when you are doing with the letrozole or CC.
Yes,
so I think we should always keep in our mind the hyperstimulation and the all other things which you have explained very well. I think it's very good lecture and very informative also. Very well spoken. Thank you, Kalyani.
Thank you so much, ma'am.
Thank you, ma'am. Thank you, Kalyani ma'am, and thank you, Aarti ma'am, for such a wonderful session.
I just wanted to make a point here. Hello. One point here. So basically, this study that you did, what happens is that but you have to keep that sample at room temperature, which is in where I was working in Ghent many years back. The room temperature was 24 degrees centigrade. So at so many times what we used to do is we used to keep the samples on the bench and do the ICSI the next day. You know, especially if you do a biopsy, then where you want to harvest the sperms, we used to make the dish and keep it at room temperature. If you keep it at 37 degrees centigrade, then what happens is the motility falls after 12 hours because of increase in the movement, and there is a ROS which is produced, reactive oxygen species, which further hampers the performance. So that paper, I'm sure that they must have kept the sample at 24 degrees centigrade. Remember that. If you keep it in the incubator at 37 degrees centigrade and next day use it, it will hamper the performance. And I just now opened on the internet, and exactly the same thing there. This paper is there where they showed that they compared sperms at 20 degrees and 37 degrees, and when they kept the sperm at 20 degrees, the performance was very good. Well, the 37 degrees, after 12 hours, the motility fell down at the 37 degrees temperature. So if you have to do it overnight, which is a good point, and I could correlate it with when I used to work in the lab in Ghent 30 years back.
Yes, sir. So basically, sir, we have always been made to, work in a way that once the semen sample is processed, that you should be immediately doing the IUI. So that is the reason I found this very interesting, that there are certain things which are other than what we have been imbibed in our mind, that, this is the certain SOP that we need to follow. So it was an eye-opening for me also. Even I had never read about it. So that is why I kept an open question for it, because inputs from you people and from the seniors is always welcomed. And it gives us much more idea about how things are changing, and so at a faster rate in the IVF, ICSI or in the IUI field. So
good.
Thank you so much, sir. And thank you, Kalyani ma'am, for such a wonderful talk. And thank you, Rishikesh sir and Aarti ma'am. We can never get tired listening to your inputs. And they really help us as fellow students to actually guide us through day-to-day practices. Moving on to our next session. It's on adjuvants in PCOS, and it gives me immense pleasure to welcome the chairperson for our session, Dr. Asha Jain ma'am. Ma'am is the director of the SMSA Hospital, and she is the medical director of Cancer Prevention and Relief Society of Raipur. She was the secretary for IMA Raipur and the vice president of IMA OB/GYN Society. It gives me immense pleasure to have you, ma'am, as a chairperson of our session. And if you could please introduce our speaker, Dr. Parikshit Tang, sir.
So thank you, Ashwini, for that introduction. And it is my great pleasure to actually introduce Dr. Parikshit, who doesn't need any kind of introduction. I don't think there's even one person in FOGSI who doesn't know what Dr. Parikshit Tank is doing, but still, As a part of the program, I would like to introduce him. He is a consultant at Ashwini Maternity and Surgical Hospital and Center for Endoscopy and Assisted Reproduction, Mumbai. He is a consultant at Jupiter Hospital, Thane, Honorary Professor, Pacific Medical College, Udaipur, and he's a consultant for assisted reproduction at 16 centers. He is the treasurer of FOGSI, and he was the chairperson Safe Motherhood Committee FOGSI in 2014 to 17, postgraduate teacher and examiner, College of Physicians and Surgeons of Mumbai, examiner for the MRCOG Part 3, and managing committee member of Mumbai Obstetric Gynec Society. I think this is a very, very short overview of his awards and publications. He's got the K. Bhaskar Rao Gold Medal for first place at DNB, Dr. Kamini Rao Yuva FOGSI Orator 2011-12, over 100 peer-reviewed publications in index journals, CME publications, and textbooks. He's co-authored 4 books in obstetrics and gynae, and he is on the editorial board of 4 index journals. He is going to talk to us about adjuvants in PCOS. So welcome, sir. Over to you.
Thank you, Dr. Asha Jain. Very kind of you to introduce me. I'm just going to start sharing my screen, and I hope that it goes on to the full screen. Is it full screen?
Yes, sir.
Yeah, okay.
It is full screen, sir. We'll remind you at the 9th minute.
Yeah, sure. And I've been asked to be brief and conclude within 10 minutes. So I'll do my best to wind up this topic within the allotted time. So let me begin right at the basic concept of what an adjuvant is. So it's an ingredient that modifies the action of the principal ingredient. Now, the problem with treating PCOS is that nobody knows what is the principal ingredient and what's the adjuvant. So, I mean, there is a list of standardly accepted treatments, and whatever we do besides that becomes the adjuvant. So I've gone with that kind of an approach. And Kalyani ran us through the standard approach of treating PCOS. So this is what it looks like. You make a diagnosis, do oral agents, then some people do a drilling. Then if that doesn't work, you go on to gonadotropin and IUIs. And then, of course, if nothing else is working, then you'll do IVF. And all along the way, you'll use a number of other medications, therapies, etc., which all fall into this basket of adjuvants. So ultimately, what we are looking for in terms of our goals for fertility care in PCOS are, first of all, to optimize this woman's health to carry the pregnancy. She's got to be fit. There should be minimal intervention to induce the ovulation, and we want high quality oocytes, or if this woman is going in for assisted reproduction, then we want high quality embryos or blastocysts. And of course, we want to avoid complications, specifically ovarian hyperstimulation. So the message here is that if we were to optimize this woman's health, then a number of them are not going to really need any fertility treatment at all, because at least half of them will start becoming ovulatory if they manage to optimize their BMI and keep it at that. I mean, it's not only about reaching a particular weight or a BMI, but remaining at that weight or BMI. So we know that there is a lot of metabolic input when it comes to the whole pathology, the pathophysiology of PCOS. And I believe the keystone really is insulin resistance. And this induces hyperinsulinemia. There's, of course, hyperandrogenism, dysfunctional hormonal secretion. There's a metabolic syndrome to deal with, and there are other psychological issues as well. But insulin resistance seems to be something which has captured the whole pathophysiology of PCOS. And that's where the story probably takes a big turn, going into hyperinsulinemia and causing a number of manifestations. The impact of all these metabolic parameters being deranged is that it induces a pro-inflammatory state. It disturbs the intra-ovarian environment, and ultimately you get either no ovulation, or you get poor oocyte quality, less number of mature oocytes, and ultimately the overall gamete and embryo quality is poorer in some of the PCOS women, especially when they are obese or they have a lot of deranged metabolic parameters. So what can we do to improve on this, to change the quality of the gamete or embryo? The number one, the big blue box, is really to correct the BMI. Then you address the other health issues, and adjuvants are actually a very small part of the whole jigsaw puzzle which we are faced with. Can we modify this? Yes, and we all talk about lifestyle modification because it benefits all fertility parameters. Metabolic abnormalities are corrected, and the long-term effects that this woman is going to enjoy from lifestyle modification and exercise are immense. I mean, they go way beyond the fertility and the reproductive outcomes. So what the ESHRE PCOS guidelines have advised is that you should have SMART measures, that is specific, measurable, achievable, realistic, and timely, which result into a 5 to 10% weight loss. And this involves not only what one eats, but it involves a lot of behavioral strategies to reduce the cues that this woman has to counteract in order to lose weight. There is, of course, nothing like a PCOS diet. Any diet which will give you a sustained calorie deficit of 30% is good, and 150 minutes of moderate intensity exercise every week. This is what we need to take as the biggest adjuvant, what we can ask women to take care of when they have PCOS. The other health issues are well known: control of glycemic parameters and hypertension. Look at their well-being. Are they having sleep apnea? How's their diet and activity overall? And also address the mental health issues, because depression, anxiety, body image, and eating disorders are more common amongst overweight PCOS women as compared to the general population. Now, insulin resistance is something which South Asian women have much more of as compared to Caucasians. And this is something which gets expressed much more in South Asian women. Therefore, it's a therapeutic target in PCOS, especially for our population. What the PCOS guideline, what ESHRE says, is that metformin is useful in addition to lifestyle management, and it can be considered in adult women with PCOS where the BMI is high for management of weight and metabolic outcomes. But if you look at the COS guidelines, the controlled ovarian stimulation guidelines by the same body, nearly at the same time, it says that routine adjuvant metformin should not be used as one of the agents for inducing ovulation. But I think here, the role of metformin in reducing OHSS risk in an antagonist protocol has been addressed. The beneficial impact on obesity and metabolic parameters has not been accounted for in the 2019 guidelines. So I believe there is a role in ovulation induction in fertility care as far as PCOS is concerned. What about inositol? And if you look through literature, I mean, you'll come across tons and tons of studies of inositol, both of all varieties of inositol have been studied. The problem is that these studies basically focus on metabolic parameter correction or BMI correction and menstrual regulation. There are very few studies which have live birth rate as an endpoint, and that's there only in 1 or 2 studies. So what the Cochrane review says is that at the moment, we don't have very good evidence to say that this is a helpful adjuvant when women are undergoing ovulation induction. A number of other drugs exist. Vitamin D, you know, what I call Babaji ka bhasma, because you can use it from head to toe. Any type of disease, give vitamin D. Then there are multivitamin cocktails, melatonin, even DHEA, which is surprising, but it has been studied. The problem again comes back to the same thing. Inadequately studied, no basis for recommendation as a routine measure for agents in fertility care. So I'm coming to the end of my talk, and I want to just spend 30 seconds on understanding and conveying this concept of scientific linkage. See, there is coincidence, there is correlation, means maybe, and there is causation. Now, to reach this level of causation, we need to be very careful when we say that something is connected as an outcome to a particular agent. So if you want to establish causation, there is a series of steps which need to be undertaken and fulfilled in terms of establishing that effect. You can't simply say that, oh, this is a wonderful drug and it helps everybody. No, that's not how it works. So if we go about it in a scientific manner, today there is very little in terms of hard clinical evidence that one can put forth, except for, of course, correcting the BMI and addressing lifestyle issues that can be advised as a useful adjuvant when it comes to ovulation induction and fertility care for PCOS women. They say when a thing ceases to be a subject of controversy, it ceases to be a subject of interest. And I believe PCOS is something which we'll be talking about for centuries and centuries to come. It will never stop being controversial. And believe me, adjuvants are probably the most controversial part about PCOS. So that's what I have about adjuvants in PCOS. I'm open to questions, and I hope I've finished in time. Thank you very much.
Thank you, sir. That was just so great. You said everything about every adjuvant available without really saying anything about them.
I almost sound like a politician now.
Yeah. So your talk was very, very, very correct, because actually whatever we know of adjuvants is what the MRs come and tell us most of the time. And there is no hard scientific evidence for anything. So this needed to be brought out, because whenever they come and, they push you that this is so good, it has so good results, and so many of your seniors are writing it. So such big names are writing it, and people get influenced. So, you brought everything into perspective. That was just so great. Thank you.
Thank you.
Thank you, sir. So I have been fortunate to listen to many of his talks when I was doing my MBBS in Sion Hospital. And since then, from my first year onwards, I've been a big fan of his lectures. So thank you, sir, for that wonderful lecture, and Asha ma'am for your inputs. Rishikesh, sir, if you are online, would you like to share some of your inputs from your practice and experience?
It's a very good lecture by him. I just wanted to, because, after this ART bill, because we do a lot of add-ons, and so I'll give an example. When 6 months back, I had a phone call from one of my patients from Assam that she had avascular necrosis. I had given her steroid, so she had an avascular necrosis of the hip joint and underwent a hip joint replacement. I was quite taken aback. So I went to the net to see, and I had just given her for 7-8 days. But I realized that even a short exposure can cause some side effects. So I personally feel that if you look at the IVF cycle standard, progesterone support till day 14 is the only accepted. The rest is not accepted at all. So we need to, all you youngsters, you need to make consent form, one page or adjuvant. Ki, Baba, this is an adjuvant. There's a lot of papers saying it gives good outcome, but there are a lot of papers that say that it doesn't give good outcome. So we are using it in good faith. There may be some side effect, because if suppose we give a medicine, like let's say get metformin and some creatinine crisis, which is some problem of this, then they'll say, why did you give it? So we need to create this and take signatures. So once we take signatures, we are safe. So like given aspirin is an adjuvant, heparin is an adjuvant, pipel is an adjuvant, PGTA is an adjuvant, you name it and it's an adjuvant. No, if you look at the HFA side, they are given color to it, red, green, and orange, amber. Only one adjuvant has been given a green color, and people, I think, is one they have accepted as amber. Rest is all green, red color means not to be used. So we'll have to create a consent document, and I'm too tired now to do anything. So I request all of you to sit down and create this for all adjuvants, to create a consent document. So that we can just sign it.
You said that we should create this document. I remember, sir, last time.
You all get together. I have YTP committee, and Parikshit is there, Dr. Rajul, all of them, Dr. Asha, all of them are intelligent, and create this document so that we can just take signature. Baba, aspirin de rahe, ye sign karo. Main to nahi dete. that way.
Right, sir. Absolutely. Thank you so much, sir. I totally agree, sir. The confusion of adjuvants and what should be and what should not be given is never ending. And the importance of taking consents is absolutely important. Thank you so much, sir, for those inputs. And wonderful session. Thank you.
Actually,
sir and Asha Jain, ma'am. And all the viewers who are watching,
Rishi sir, you are muted.
After these
sorry, no,
sessions, we
I'm
have
just saying with the ART bill, there's a grievance box that has to be prominently displayed. कि आप बैल मुझको मार के बाबा अभी complaint डालो. So that's why now we have to be very careful now. So all of you, please, now we are in a different era. We have to be we don't know how the implementation of this act will take place. So you have to be very wary. You have to be very on the guard. Till we come to know what's happening in the next 1-2 years, you must be on your guard totally.
Sir, may I add one little thing? The new NMC draft bill has also come up. And it would be useful if everybody actually read it, because all our programs have MRs involved and companies involved, and there are a lot of rules regarding that. So we really, all of us need to read that and give our inputs into it. Otherwise, in a couple of years, we are going to be really in a soup.
Totally agreed. We'll totally agreed. So we'll now get on. Otherwise, we'll go into a different track only.
Thank you so much, sir. Thank you, ma'am. We'll move on to now the third session. So I request all the audience to stay back now. So requesting this third session is actually about the tubal patency test. So we have a speaker, Dr. Sheetal Savankar, ma'am, and our chairperson is none other from the Agra Society, Dr. Savita Tyagi, ma'am. Can you please have our CV? Dr. Savita Tyagi, ma'am, is the director and senior consultant of the Ishwar Nursing Home, as well as chairperson of the IMS Rural Committee of the 2021 presently, and is the secretary of the AOGS. I request Dr. Savita Tyagi, ma'am, to please introduce our speaker, Dr. Sheetal Savankar, ma'am.
Ma'am, please unmute. Madam, unmute.
Ma'am, please unmute, ma'am.
Thank you so much, Niharika, for making me part of this YTP committee. And it's my pleasure to introduce Dr. Sheetal Savankar. She is MBBS, DNB, MNA, MS, and FICOG, Diploma in Reproductive Medicine, and Master in Reproductive Medicine UK, and Fellowship in ART. She is a director, Surya Fertility Clinics, Youth Council member, MOGS. She's from Mumbai. Awards recipient of MOGS RD Pandit essay writing on reproductive health in his wealth in 2012 and 13. Recipient of MOGS Dr. N.A. Purandare Award of paper on comparison of mild and conventional stimulation in poor responder in 2014 to 2015. She has so many awards in her CV, and it's to you, please, I will not come between you and the lecture.
Thank you so much, Savita ma'am. Thank you, Niharika, for inviting me. Thank you, Priyankur. And thank you to the YTP committee for letting me speak on this topic. I would like to share my screen.
Ma'am, I'll give you a reminder at 9th minute.
Yes, yeah, sure.
Thank you so much, ma'am.
Is it seen?
Yes.
Yeah.
Yes, ma'am.
Okay. Okay. So today I'm going to speak about tubal patency tests. Obviously, it is very important from an IVF consultant or a fertility specialist point of view, because if the tubes are not patent, then our treatment modality changes. If tubes are not open, then we have to think about IVF or whether the patient is going to need IUI. So I'm going to speak about introduction, different tubal patency tests, what is its effectiveness and the safety, the algorithm, and obviously the summary. Infertility affects around 1 in 7 couples and is defined as an inability to conceive after 1 year of unprotected intercourse. Tubal disease is an important cause, accounting around 25 to 35% of female infertility. So it kind of takes a huge chunk of infertility in females. And accurate evaluation of tubal patency can provide an important evidence for clinically targeted treatment approach. What are the different causes of tubal factor infertility, tubal blockage? It kind of ranges from different pathologies, including obstruction, stenosis, dilatation, and impaired peristaltic functions. The most important cause, as we all know, is PID. Other causes can be endometriosis, previous pelvic surgeries, fibroids, and in India, because we have TB, which is very common. And obviously, sometimes it can also be because of IUDs. The different types, I've tried to cover all of them. A lot of them we don't even do nowadays, but I've tried to just for covering all the topics. So the most commonest test that is done is laparoscopy and dye test. Then there is saline infusion sonohystrography. Then there is HSG, which is routinely done by a lot of gynecologists as well as infertility specialists. Then there is HICOZ, and there is hysterosalpingo foam sonography. Then there is transvaginal hydrolaparoscopy, selective salpingography and tubal catheterization, salpingoscopy, phalloscopy, fertiloscopy, and then there is chlamydia antibody test, which I'm also going to speak about. Now, laparoscopy and dye test, it is the commonest test. It is the gold standard for evaluating the tubes. The advantages, as we all know, it is the gold standard investigation for tubal assessment. It allows direct inspection of the fimbrial ends and assessment, because we are actually visualizing an assessment of the pelvic pathology, such as endometriosis and adhesions. It also enables, if there are any other pathologies, because anyways the patient is undergoing anesthesia, you can also do hysteroscopy and therapeutic procedures such as tubal surgery, hysteroscopic tubal cannulation, ablation of endometriosis, ovarian cystectomy, and adhesiolysis to be undertaken concurrently. Now, what are the disadvantages is assessment of internal architecture of the tube is not permitted, because obviously it is from above, and it is not always possible to identify the site of tubal occlusion. It is an invasive procedure, costly than the other forms of tubal assessment. It requires general anesthesia in most cases, and it is also associated with 0.13% risk of bowel, urological or vascular complications. Now, this is saline infusion sonosalpingography. If at all a patient has come for the first time and it's a young couple, this is my preferred choice. It is media used is isotonic saline solution. The appearance of fluid in the Culday's sac with saline infusion confirms tubal patency. The advantages are it is very less invasive and easy to administer. No anesthesia is required. Eliminates the need of iodinated contrast and ionizing radiations. The disadvantages, it does not differentiate between unilateral or bilateral patency, and there are some chances of infections. But I used to visit this sonologist where they used to do this, they used to see the flush on the scan, which was much better. So we could actually differentiate which side also in SIS. So that was an advantage which I could see, where you could actually diagnose whether both the sides are patent or not. So that was something which was that sonologist used to do. So in that we could actually see which side also, whether it was patent or not. So gold stand, a lot of people still do hysterosalpingography, but I somehow feel it is painful. It is traditional and a standard method, a radiographic evaluation method. Now, radio-opaque, water-soluble iodine dye or an oil-soluble contrast medium is used. Can identify proximal and distal tubal occlusion if there is no spill, fimbrial phimosis if there is a delayed spill, or peritubal adhesions if there is a loculated spill. What are the advantages? Is it is cheap and widely available. In fact, a lot of places SIS is not done, but HSG is done at most of the places due to longevity of the use. Has the largest evidence base to rule out unilateral or bilateral tubal block. Has a low sensitivity but a high specificity, that is around 87%. Disadvantages is sometimes if the catheter is not introduced properly or instrumentation is not done, if it is not sealed properly, it does not give a good result. There can be a false positive result because of tubal spasm. So that is, a lot of times it happens that the results come negative because of false positive because of tubal spasm. And there's an ideal time that it is generally to be done on the 7th or the 8th day of menses. So sometimes there can be delays or scheduling problems. There is a radiation exposure which is much higher than a chest X-ray. And there is 1 to 3% risk of infection or a flare effect. And most importantly, it is very painful. Most of the patients say that we don't want that kind of pain. The experience is really, really bad. So these are few images of the HSG. This is one picture which talks about which shows peritubal adhesions. The second one shows an hydrosalpinx, and the third one shows a right tubal block. Now this is an HyCoSy, a very good test. It is a transvaginal ultrasound technique, which is kind of avoiding the radiations. And it is a water-soluble contrast medium which is injected into the uterine cavity using a 5 French or a 7 French catheter. It is an outpatient setting test with the woman in the semi-lithotomy position, which allows easier access for cervical catheterization. What are the advantages? It allows simultaneous examination of the endometrial cavity, uterine morphology, where 3D can also be done, and fallopian tubes while avoiding radiation exposure. It has 90% efficacy in evaluating the uterine cavity, minimally invasive and well tolerated. Now the disadvantages are significant technical difficulty may be encountered in obese women and those with acute uterine retroversion and high ovaries. There can be some discomfort, and occasionally the women can have a vasovagal reaction. There's also something called as a hysterofoam sonography, that is FOGSI, where foam is put in the system. So that is also something that is done in some patients. Now, there are a lot of studies which are done where the data is pulled from multiple studies, which indicates a high sensitivity, specificity, and a good patient tolerability for HyCoSy. On a comparative basis, HyCoSy is more sensitive and specific than HSG. A variety of contrast media can be used. And in fact, they say that for the cavity check, SIS is very good. And for the tubal check, hysterosalpingo foam sonography is very good, where XM foam can be used. Now, this is a test which is called as the THL, that is the transvaginal hydrolaparoscopy, where it involves the insufflation of the pelvis with 0.4 to 0.6 liters of fluid medium through the insufflating needle, which is pushed through the posterior fornix, which is followed by introduction of a small diameter rigid angled endoscope, which is used to visualize the pelvic side walls, which is introduced into the POD, which is used to visualize the pelvic side walls, adnexa, and the tubal patency. And the dye is injected transvaginally. It is performed as an outpatient setting under local anesthesia, and even minor operative procedures can be performed like adhesiolysis, diathermy to endometriosis and salpingostomy through the operative channel. It is the single biggest risk in this procedure is bowel injury, either at the time of insufflation or at the time of introduction of the endoscope. This is how the setting is done in this procedure. Then the next one is selective salpingography, which involves the direct injection of radiopaque dye into the tubal ostium. And this is done by the introduction through the transcervical route under fluoroscopic control, as a result of which it significantly reduces the false positivity which we see in HSG and when there is a tubal spasm and debris. This is a second-line treatment to improve the accuracy of HSG or laparoscopy in the diagnosis of especially proximal tubal blocks. It allows direct measurement of tubal perfusion pressures, which also has a prognostic value, and it can be combined with tubal catheterization to treat proximal tubal obstruction. Now, this has a risk of tubal perforation during catheterization, which is around 2%, and ectopic pregnancy, that is around 3%. The procedure adds to the operator time and radiation exposure to that from a standard HSG. The next method is salpingoscopy. Salpingoscopy is an endoscopic visualization of the endosalpinx of the tubal infundiculum and ampulla. And it is basically, there are various other techniques like falloposcopy, where you can do an endoscopic visualization of the whole endosalpinx at hysteroscopy. Falloposcopy is done during the mid-follicular phase of the menstrual cycle, because obviously at that time the patient is not menstruating, and you can visualize the tubal ostium, especially when there is absence of blood and thick endometrium. And fertiloscopy is an outpatient technique which combines hysteroscopy, THL, and salpingoscopy. These all techniques provide significant additional information, but currently there is no universally agreed and validated system to classify normal and abnormal findings, and therefore there is a lack of prognostic ability. These are some pictures which show endometriotic implants on the tubal serosa as seen at laparoscopy, and salpingoscopy in tubal endometriosis. These are the techniques where you can see how the scope is put in and to see the inside of the tubes through the scope. Now, this is a chlamydia trachomatis antibody test. It is chlamydia trachomatis, as we all know, is the largest cause of acquired tubal pathology, and evidence of both current and past infections can be easily measured through the chlamydia trachomatis antibody test. We all know that the sensitivity is around 21%, but the specificity of a chlamydia, if the patient has antibodies positive, is very high. It is almost 29 to 100%, and it depends on the various cutoff values used to define the positivity of the test. And amongst all the tests, MIF, that is microimmune fluorescence, is more accurate compared to ELISA or immunofluorescence assay. There are various cutoff values, and they say that if it comes positive, then the correlation between the positive test and the infection rates or the tubal pathology is very, very high. So these are various tests which they have put the sensitivity and the specificity. If you see, HSG, the specificity is around 87%, but the risks of exposure, anaphylaxis, PID are slightly higher. If you see the CAT test, the specificity is around 29 to 100%. And HycoSy, if you see the sensitivity and the specificity, both are quite high. So if given a choice, you have to decide, and laparoscopy, obviously, you know that it is a gold standard. So you have to choose which test works best for you. This is a small algorithm which we have put where you feel that if you feel that the patient is likely to have a tubal disease, if you feel that the patient has it, then the best obviously is to have a laparoscopy and a dye test. If you think that no, you just want to evaluate it, then if HycoSy is available, you can go ahead with an HycoSy. If it is not, then depending on what is convenient, an HSG or an saline infusion salpingoscopy can be done, or salpingography can be done. And if there is allergy, then an HycoSy can be done. To conclude, I feel the pathogenesis of infertility is multifactorial. Investigative and treatment approaches should be therefore individualized. There are many tests for tubal patency with their relative usefulness. However, none of these tests address all aspects of tubal function. A policy of universal invasive tubal patency test is to be discouraged. Instead, the investigation and management of tubal factor infertility should be individualized on patients and populations. My only thing is that even if there is a tubal pathology, you have to understand that you cannot actually go and treat tubal pathology because there are very high chances of ectopic pregnancies. So in that case, I feel IVF is the way of treatment of choice, because they will end up having more ectopic pregnancies. So if there is a tubal pathology, so that is my conclusion, what I have seen in my practice. I'm ready for any questions. Thank you.
Thank you so much, Sheetal ma'am. Really applaud the versatility by which you have presented this topic. Savita Tyagi ma'am, our chairperson, would you like to share some of your inputs on your experience with the tubal patency test now?
Dr. Sheetal has covered each test in so detail. I think I have nothing to add, but yes, still today, the laparoscopy is a gold standard, but it is not possible for all of us to do as a routine. And you have covered all those things, whether HSG is still the most popular test, I think, for most of us. Although we should go for the SSG and to do ourselves so that we can know more about the patency of the tubes as well as other pathology we see at the same time. But still today, this laparoscopy is the gold standard. Thank you so much, Sheetal. You have covered each aspect and what are the advantages and what are the specificity and sensitivity of each test. Thank you so much, Sheetal. And if anyone is having any question, or sir,
I wanted to, Sheetal, so
sir,
basically you, normally a patient comes to you, you will do ultrasound, everything is normal. You will do an HSG maybe, that's how what I do. You may do a HICOC and then you do 3 IUI cycles and she fails. Now will you do a laparoscopy? That is the and I want everyone's hand because that is the moot question. I'll tell you, when I joined Lilavati in 1998, I was very active. So I did a laparoscopy and we had a bowel injury. And and it was a donor insemination. मैं तो बहुत tension में गया. बोला यार कुछ हो गया. She went into ICU and all. I was really tensed up. And then I said, oh, if there's a problem and then the debate will come, why did you do a laparoscopy? Because we had come from KEM and all. There every second patient you do laparoscopy. Bindas. So now this is another important thing for, there's Chaitanya Shembekar also there. We need to create a guideline. Because if there is a death on the table, let us assume that you did a laparoscopy and there was a death. There can be a controversy whether you should have, because if you look at the American groups and all, unless there's a pelvic pathology or a symptom, they will go directly from IUI to IVF. They don't do a laparoscopy because it's interventional. There has to be a mass or there has to be an acute symptom indicating endometriosis. We have got a player called tuberculosis, which can't be made out. So laparoscopy helps us in deciding. So what will all of you do? Will you do a laparoscopy and then do IVF or go directly for IVF? And if so, if we have to publish this so as an opinion so that tomorrow if there is a litigation, then we can quote that publication.
Direct to IVF, sir.
So we will not do, at least I in my practice directly shift to IVF.
But then how do you diagnose tuberculosis? If there is a tuberculosis, how will you rule that out?
That could have been picked up with...
Suppose you do IVF and fail and then someone of your Kalyani Srimali puts a scope and says, "Arey, ye to tuberculosis tha. Sheetal ne 3 IVF kiya, karna nahi mangta tha pehle. AKT deke fir IVF karta tha." So then how will you answer that question?
HSG also could have picked up a tubal pathology, no, sir. So there's no need for a laparoscopy to pick up tuberculosis.
So now tell me, how many of you, please raise your hand, after 3 IUI failure, HSG is normal, ultrasound is normal, how many of you will still suggest a laparoscopy and how many will go directly for IVF?
How many patients will actually have TB after so many things being normal? Because TB will have some pathology.
Baba, I tell you, give an example. When I was young, I had gone to Bihar to give a talk. And when I was drinking tea, one gynecologist said, "Sir, हम तो सबको AKT देते हैं पहला. Infertility होता है तो पहला सबको AKT देते हैं." So there's a lot of group of people who believe and swear that there's a massive tuberculosis in the country. You go to All India Institute, they'll get scandalized. If you talk like this to JB Sharma, he'll say, "What is he talking? His whole life is on tuberculosis."
Sir, Dr. Bomsi Wadia used to give anti-AKT to all his patients.
So that's what I'm
saying. They said that in
so,
India, TB is in air.
He says
TB is in air.
So Chaitanya, what would you do? I don't want to derail your meeting so that I'll not take much time.
We will avoid lab, sir.
Avoid lab. So the general consensus is that you avoid laparoscopy. Barabar? Aditi Tandon?
PCR we do, but I don't know how
surgeon Aditi Tandon, what does she do?
Yes, sir. I think I agree with you. Unless the HSG shows like a tubal pathology or a hydrosalpinx, for which you may need to do clipping of the tubes, or like an adnexal mass which could be there in tuberculosis, only then laparoscopy. If the tubes are normal, then definitely not laparoscopy. Directly do an IVF.
Okay. So, General Dr. Sita.
Yes, sir.
What is your opinion?
Well, I think coming nowadays with all these, as you said, with litigational practices, clinically, if there are no suspicion of any problems, if the imaging, whatever you've done, everything shows normal, we don't stand any grounds to do an invasive test and prove our point. And if she's going to have a laparoscopy and then eventually end up in IVF anyway, I think we can straight away go in for IVF and then decide. But again, I think all these needs to be discussed with the patient and say that these are the options, this is what is recommended, and then it is for the patient to choose. If she still wants to go ahead, because otherwise tomorrow she might come and say, well, you didn't do a laparoscopy, my other friend had a laparoscopy, you know, those sort of things. I think if we put all these things in front of her and tell that this is what is it, this is invasive, this is non-invasive, and then maybe if you go in for IVF, you avoid an invasive operation, you save time, and then you get results quickly. So, and then it's the patient's choice what she wants. But most of them, I think, would directly go in for IVF rather than having laparoscopy. And so that's my opinion. Thank you.
So that way, every patient will undergo laparoscopy, because India.
But, you know, there is our teaching hospital that's still the norm. No? Many people, I don't know now what is it, but during our days, everyone used to do scopio. Anyway,
we moved away from that those days, isn't it? We've moved away.
I don't know what's happening in the teaching hospital now. Yeah. So, because you will know probably younger generation. Anyway.
Great. Thank you so much, sir. Thank you.
Yeah, I just
Thank
want
you. Thank you so much, sir. Yes,
yeah, if there is a suspicion of endometriosis, maybe for unexplained infertility, or maybe if the patient has dysmenorrhea, then laparoscopy has a role, but not otherwise.
Not otherwise. Clinically, there is any suspicion, or that's what. Yeah.
But as Sita said, you give the choice to the patient.
33-year-old with a low AMH, will you do laparoscopy?
No.
No. Low AMH, 0.3 AMH is there. There is a possibility that there may be a tuberculosis inside damaging the ovary. Will you do a laparoscopy?
There's a suspicion you always do, sir. There's no suspicion.
She's a 33-year-old, clean pelvis on ultrasound. HHG is okay, but AMH is 0.3.
Why a laparoscopy for that? Ovarian
disorder. Not infection, ovarian damage.
Usually some symptoms will be there, sir. Without symptoms, they do not have such a...
अरे यार, tuberculosis की बात कर रहे, brain का, भेजे का, liver का, heart का होता है. KM में every year 90 doctors get tuberculosis, and most of it is silent. Anyway.
Yeah.
The patient's choice at the end of it.
What Dr. Sita has said is correct. We need to counsel the patient. And we say there is no role of laparoscopy anyway. It's better to go for IVF. However, if you want, we can do it. And forget about it. But yes, if I get a patient with previous 2-3 IVF failures, I get a lot of these patients, they have done direct IVF, they come to me after failures, then I will definitely put a scope in.
So one of my patients wanted a laparoscopy. We put it, she had severe endometriosis with no symptoms at all. Totally, the pelvis was
I have got so many patients of failure when I put scope, they have massive cocks and all that. So
sometimes it happens.
Sometimes even after scope, they conceive in the next cycle.
That also happens.
Flushing of the tubes.
Diagnosis of tuberculosis is becoming difficult.
The more they spend, they become pregnant the next time.
And the problem is diagnosis of tuberculosis is becoming difficult. TB-PCR 10 years back, we used to get 100% positive results. If you find tuberculosis on laparoscopy, we would say that this is positive, and we used to get positive reports. But nowadays, TB-PCR reports never come positive. I don't know what is the problem. So it's difficult to diagnose.
TB-PCR has no value. TB-NAT has to be done.
No.
Yes, that is what.
Same question. If you're putting the scope inside, we are seeing that there are tubercles, but when we are sending out the test, in case if they come back negative, are we still going to start AKT? Because according to the newer guidelines, we are not supposed to start any AKT.
There is no role
unless the culture is positive. That is what they say. Unless the culture is positive, you're not supposed to start AKT.
Even when we are putting the scope and we are finding that probably it's a frozen pelvis, or we are finding that there's a symptoms, are we still without the test?
Yes, we can surely, according to National Tuberculosis Program, also, madam, I am in Government Med Teaching Institute, and on clinical basis, if we are suspecting, then surely we can start ATT, and many times we have to do it.
Ma'am,
we can start AKT, but we have to notify government. We have to notify.
Yes.
We have to notify government.
Niharika, you have to cut it out now.
I just wanted to.
Yes, sir. We'll definitely keep tuberculosis as.
Yeah. Now, I just wanted to add here that there are two things. We are looking at active tuberculosis or sequelae of old tuberculosis. If there is active tuberculosis, you have to prove it by a biopsy, and then giving treatment makes sense. But if she's already had tuberculosis and the sequelae is blocked tubes, just giving AKT is not going to help here. That's my opinion here. Thank you.
Thank you, everyone. And I think next
much.
webinar is only tuberculosis now.
For sure.
Niharika already found a topic for the next webinar.
Ashwini, chalo, let's go ahead.
Yes, ma'am.
Thanks, Niharika. Thank you, sir.
We'll go ahead with the next session. Thank you so much. Thank you so much. We'll continue with our next session, which is on genetics and infertility. I would love to introduce our chairperson for this session, Dr. Sita Ramamurthy Pal, ma'am. Sita ma'am is a consultant in fetal medicine and obstetrics of Apollo Hospital, Kolkata, and she is the clinical secretary of Bengal OBGY Society. She is the examiner of MRCOG Part 3 as well as the member of the National Board Specialist Committee of Maternal and Fetal Medicine. We welcome you, ma'am.
Thank you, Ashwini.
For our session 4 on genetics and infertility. Kindly, I would request you to please introduce our speaker, Dr. Veronica.
Thank you so much. Thank you, Dr. Ashwini, for that kind introduction. And at the outset, I'd like to thank YTP Chairperson Niharika, my dear friend, and Dr. Priyankur for involving this wonderful program. I've been listening to the lectures. They've been wonderful with great messages and take-home messages. So congratulations and respect and regards to all the seniors here, Dr. Pai, Dr. Archana Verma, Dr. Rajendra Singh Pardesi. So thank you, Niharika, for that. And I think with another very important topic of genetics, I think with advances in medicine, a lot of lab medicine and reproductive medicine has joined together. So we have seen a lot of advances. And I think genetics plays a crucial role in all aspects of reproductive medicine, starting from preconception to delivery. And you could have a day full on genetics and infertility. So I will not like to waste time on this. So covering this topic is going to be Dr. Veronica Arora. She's an associate consultant and assistant professor, Institute of Medical Genetics and Genomics at Gangaram Hospital. She's an executive member of Delhi SFM. She's a DNB gold medalist with more than 50 publications in peer-reviewed journals, and she's had several awards. Her special areas of interest include fetal malformations, autism, skeletal dysplasia, genetic metabolic disorders. So no one better to talk about this topic. And over to you, Dr. Veronica. Thank you.
Thank you so much, ma'am. At the outset, I'd also like to tell you I have done my gynae as well from Kolkata. So it's a pleasure to have you.
Oh, that's so nice.
So thank you so much, Dr. Niharika and YTP for having me here. And I would like to pay my regards to all the seniors who are present here. Genetics may not be a very interesting topic for obstetrician, as I understand, but it is something that we in this era cannot ignore, and we all must try to understand as much as we can and try to make it interesting. So I'll just share my screen now. So I have decided to start with male infertility, especially because this is something that we as obstetricians read a little less about than female infertility. So before we start, let me just give you a little brief of what genetic disorders are and what we really look at when we talk about genetics. So as we know that we all have these 23 pairs of chromosomes that are present. Now this whole, these are the chromosomes that are present, and from the chromosomes, as we can see, arises DNA, and on DNA we have nucleic acid. So chromosomes are the basic unit of genome, and on chromosomes are present genes. So when we divide the testing in genetics, we divide it into two parts: the cytogenetics and the molecular genetics. The cytogenetics is about chromosomes, and the molecular genetics are the tests of the genes and the sequence on the genes. So when we talk about cytogenetics, there are three important tests we all should know about. The first is the karyotype, which shows in a graphical representation how all the chromosomes are present. And it also shows us any losses or any gains that are present in the chromosomes, as we can see. Karyotyping is the test of choice in recurrent pregnancy losses for the couple. For a couple who presents to us with recurrent pregnancy losses, there is no other test we offer except karyotype, and it is the first and the most important test. This I just bring out to emphasize that chromosomal microarray, though a better test for other situations, should not be offered to couples with recurrent pregnancy losses. So now this is a karyotype, and when we see here, a male has an X and a Y chromosome, and the diagram on the top right side shows a Y chromosome in detail. And the important part of Y chromosome is the sex-determining region of Y, and also the part in light blue is the euchromatin. Euchromatin really means the part of the chromatin that is the part of the chromosome that encodes a coding or an informational DNA, and the other part is not that important. So there are three regions present on the X chromosome that we will focus on. That is the AZFC, azoospermia factor A, B, and C. And this is what we will check for males with azoospermia. And now those were the tests for chromosomes, and we have to remember the Y chromosomes in male infertility. When we talk about the genes, we talk about two important parts of the gene, that is the coding region called exons and the introns. So the study of the coding region is known as exome sequencing. We all hear a lot about these texts about whole exome sequencing and whole genome sequencing. So my message really here is that in today's era, the test of choice for most of the situations is a whole exome sequencing. It will look at all the coding areas of all the genes present in our genome. So what are the indications of testing a male with infertility? Do we offer these tests to all the males? The answer is no. So if there is severe oligospermia, a non-palpable vasa for cystic fibrosis, or a non-obstructive azoospermia, those are the indications for genetic testing. The utility really is that once we have a cause, we can provide a better personalized treatment and improved risk assessment for transmission of infertility to the offsprings, because even if we can do an IVF for such individuals and there is a problem in the Y chromosome, it would be transmitted to the next generation. Also, there would be better counseling for potential health risk in infertile men. For azoospermic men, prior to testicular biopsy, finding a genetic diagnosis may help in predicting the chances for a successful testicular sperm extraction, which is an incredibly invasive procedure. And then, of course, cascade counseling. Cascade counseling means counseling or looking after the other family members and seeing their genetic risk as well. Now, what is the contribution to infertility? Approximately 4% of all infertile men are diagnosed with a genetic cause of infertility, but majority remain with the without a diagnosis because the lack of awareness of these genetic testings. The main factors for male infertility include factors from the hypothalamus to quantitative, qualitative spermatogenic defects, and finally the ductal obstruction or dysfunction. So genetic testing, of course, is not indicated for all infertile men. You do not perform or indicate genetic testing if there is previous fertility, there is a known prior gonadotoxic exposure, the examination is highly suspicious for an ejaculatory duct dysfunction. So here we do not do a genetic testing. So there is an indication for genetic testing, as I spoke, for a non-obstructive azoospermia and oligospermia, or a non-palpable vasa. Those are the three tests where we do a genetic testing. We just have shown that. So now we come on to a common thing that we keep hearing in genetics, that is the congenital absence of vas deferens. So this congenital absence of vas deferens is related to a genetic condition known as cystic fibrosis. But every individual who has a congenital deference of vas deferens will not necessarily have cystic fibrosis. So we need to check for those. So this entity should be suspected in men with a severe oligospermia, a low volume of ejaculated semen, or evidence of abnormality of seminal vesicles. So the most commonly associated genetic abnormality with this entity is cystic fibrosis, and we can do a clinical exome sequencing or sequencing of the CFTR gene for such individuals. So this disorder has an autosomal recessive inheritance. That is, 25% of the offsprings will have this disorder if the wife is also a carrier of the same gene or the same mutation. So when you have an individual with cystic fibrosis, most of the time they will conceive because they will have sperms. It is just an obstruction. So we have to test the female partner as well to make sure the disorder is not carried forward to the offspring. So men with CBAVD typically have normal spermatogenic potential and therefore are excellent candidates for artificial reproductive technologies. They should instead also undergo renal imaging to look for associated conditions. And the most important message here is the partner of men with CBAVD should be additionally screened for attempts for ART in order to identify cystic fibrosis in their offspring. So now when we have men with cystic fibrosis or cystic fibrosis related duct dysfunction, we do a clinical examination, a semen analysis, and then we can do an NGS-based exome sequencing. That is the test of choice, and we can then identify the mutation and also offer prenatal diagnosis if required. So this is the
2 minutes left.
Yeah, so this is the test of choice for, as ma'am said, this could take one day. I have tried to summarize this in like 15 minutes. So please pardon me with the time. So the next generation sequencing based testing for this entity is the CFTR and 5T70 allele polymorphism. I know it is not very easy to understand, but we can order an exome sequencing and of course consult a genetic counselor, a fetal medicine or a geneticist for such cases if we have any. Except cystic fibrosis, now there are other genes which are also related to CBAVD. So now we come on to the Y chromosome defects, that is some deletions, the micro deletions in the azoospermia factors, that is the AZFA, AZFB or AZFC micro deletions are also known to cause infertility. So 7.5% of all oligo and azoospermic men will have this problem. And due to the relatively high frequency of Y chromosomal micro deletions, both the European and the American Society of Male Infertility recommend offering these tests to all men with oligospermia. So the test of choice here would be a MLPA based or a PCR based or a chromosomal microarray for looking for the microdeletion. The most used test is an MLPA based test to detect these deletions. So I'll just skip through these and come on to a more commoner disorder, that is Klinefelter syndrome, which we all know also has male factor infertility. There's an extra X chromosome, so the complement really looks like XXY, and these people also on fish will have an extra X, as we can see here. So except these common disorders of male infertility, there are many other genes that can also contribute to male infertility. And if we want to see the genes, this is just in a nutshell, in a snapshot, that there are many genes which we can test for. And all this can be found out in one test called the whole exome sequencing. So now we just come quickly to the female factor infertility. We all know a premature ovarian insufficiency is when there is a scant or a deceleration of ovarian function before the age of 40 years. And they account to the Turner syndrome results in an unbalanced X autosomal rearrangement or a loss of X chromosome, and it causes an accelerated loss of primordial oocytes during female fetal development, and it accounts to 10% of the premature ovarian insufficiency cases causing female factor infertility. So this is something you can look at the knuckles of the girl, and if there is primary amenorrhea, even if there is no primary amenorrhea and the AMH is lesser, a karyotype must be performed to rule out Turner syndrome. You can perform a FISH in addition to karyotype to look at mosaic Turner phenotype. So the prevalence of Turner is actually quite common, 1 in 2,000 to 2,500 individuals. In a prenatal setting, NIPS is not a good method, especially for Turner syndrome, as it has a very high false positive rate as well. So here there is a missing X. So karyotype is the test of choice if we are suspecting Turner syndrome. So I think we all know Turner syndrome very well. So I will skip it and just come on to other a little less common disorders of XY gonadal agenesis and XX gonadal agenesis. Both of them are caused by mutation in certain genes which code for the formation of the genitalia, formation of the uterus and the ovaries. And all these can be detected after you have identified an XY in a female when you sequence all the genes which are known to cause these disorders by a test called exome sequencing as well. Another important and a very common syndrome is Fragile X syndrome, in which the males have intellectual disability. So if you have a woman whose children or whose brothers have intellectual disability, autism, or abnormal behavior, this is a test you must offer her. The test is called Fragile X methylation PCR. In this disorder, what happens is the female herself will have premature ovarian failure, and the sons or the brothers will have intellectual disability. It's an X-linked disorder. That's why the female has a little milder phenotype than the brothers and the sons. So when we are suspecting a premature ovarian failure, we can also order a simple test for Fragile X, which costs just around 2,000 to 3,000 rupees. If you have a dysmorphic female who presents to you with small eyes ptosis, this is a syndrome of blepharophimosis, ptosis, epicanthus inversus, and infertility with ptosis, we should think of this disorder as well. When there are associated diabetes or pancreatic failure in females with infertility, we also must think that there is some deficiency in the powerhouse of the cells, that is the mitochondria. So we can test for those also. So finally, this is my final last slide. When we have a female with premature ovarian insufficiency or primary amenorrhea or infertility, one of the most important tests we all do is perform a karyotype. In addition, we must do a Fragile X PCR, that is a Fragile X triplet repeat PCR, and also an exome sequencing only when we think that the family history or the disorder or the extra manifestations that she has is suggestive of a genetic cause. Thank you so much.
Thank you, Dr. Veronica.
So much, Veronica, ma'am,
for covering this vast topic in just 10-15 minutes. It's indeed difficult, but you've done justice to it. I think I'll just sum it up saying that, in genetics and basically infertility, you need to do it for three main reasons: to find what the cause of the infertility is, to see if that can be transmitted to the offspring, and thirdly, whether you can optimize your ART technique so that the best results can be obtained. And barring the Y chromosome deletion and karyotype to rule out Turner's mosaic, any other genetic testing should be ideally be in consultation with a genetic counselor, so that you don't use tests just for using it, because they are expensive and sometimes you don't know how to interpret it. So it is important to do the right test for the right indication on the right patient. So, use a genetic counselor if available and then go on further with those. Thank you. Thank you, Veronica, again, and thank you, Niharika, for this opportunity. Thank you.
Thank you, Sita ma'am. Ma'am, we'll just rush towards the debate right now because we are running short of time. We'll have a lot of discussion with the panel upcoming. Thank you so much, ma'am, and thank you so much, Veronica ma'am, for the same. We have the debate right now for the topic of the preferred of the drug of choice, that is IUI. We'll stick to we welcome Dr. Chaitanya sir, who is 5+2. Dr. Shembakar sir is actually an obstetric gynecologist, IVF consultant with a laparoscopic surgeon in the Omega Hospital, as the president of Om Charitable Trust Foundation, and the past president of Nagpur OBG Society. Sir, I hope you take it from here, and I'll wish you to introduce Dr. Akriti and Dr. Yuvraj sir.
Okay, so good evening, everyone, all young boys and girls. We have a very interesting debate on letrozole versus CC in IUI, and we have Dr. Akriti Gupta as one of the faculty. She has done her MS OBGYN from Jammu, and has done fellowship in reproductive medicine from Kerala. She's and MRCOG Part 1 London. She also cleared. She is currently working as a fertility specialist and IVF in charge at Sri Mahant Indresh Hospital, Dehradun. And she is secretary of ISAR Uttarakhand chapter, member of Youth Brigade of PCO Society, and also has work experience of active involvement in awareness campaign run by NGO, that is Pinkish Foundation, and co-head of TPS Bardhaman Society. So welcome, Akruti. Our next debater is Dr. Yuvraj Jadeja. Yuvraj is also a very well-known speaker and a faculty in various conferences. He has done a diploma in advanced gynec endoscopy from France, and has also done ISAR Aspire Fellowship in Reproductive Medicine, and also fellowship from Kiel School of Germany. Medical Director of Niramaya Women's Clinic, Vadodara, and he is honorary professor and head of infertility department of Karmas's Medical College, and has published many scientific papers and research papers. He is also featured in DOI, Indian Express, and various other national newspapers and national channels as well. And he is also a very dear friend of mine. So welcome, Yuvraj, for this debate. So I think we'll start with Akruti first.
Thank you so much, sir. I would request to share my screen.
Ma'am, we'll give you a reminder at 4th minute.
Sure. Is it visible?
Yes.
Yes, ma'am.
Yeah, thank you, everyone. I would like to be very thankful to Dr. Niharika ma'am and Dr. Priyankul for having me for this debate, and really privileged to be speaking on the topic letrozole, which is superior to clomiphene. And at the outset, we have Dr. Yuvraj, and it's going to be a wonderful debate. So let's start with the topic. So I'll be speaking for the topic as letrozole is superior to clomiphene. The flow of presentation would be, we'll be talking about on the background of letrozole, how it acts, its advantages over clomiphene, and then a few studies justifying its superiority to clomiphene, and finally the conclusion. So we know that letrozole is a 3rd generation aromatase inhibitor, and it's used as an ovulation induction agent since 2001. In 2005, there was a buzz that it was having a risk of congenital anomalies, and approved at an ASRM conference. Thereafter, in 2011, it was withdrawn from the Indian market, and then in 2017, it came back. So the mechanism of action is that it is a competitive inhibitor of aromatase enzyme, and therefore it inhibits the conversion of androgens to estrogens, thereby resulting in an increased production of estrogen biosynthesis at all tissues wherever it is present. At the level of the ovaries, what it does is it increases the follicular sensitivity to FSH, and hence accumulates the androgens, which also synergize the activity of FSH. So what secondly it does is it upregulates the endometrial receptors in the endometrium and leads to a rapid endometrial growth once the estrogen starts increasing. So here proves its beneficial actions. We'll just have a major differences seen how clomiphene and letrozole are different. So this wonderful slide actually depicts why we prefer letrozole over clomiphene. We see that the clomiphene is basically a SERM. It is a receptor modulator, and what it does at the hypothalamic level is that it suppresses, it inhibits the receptors, and therefore by the negative feedback, it starts increasing the FSH. There, what happens is, since it's having a long half-life of 5 to 7 days, so it would the rising endogenous gonadotropin levels would stimulate the follicular growth, and even the rising estrogen levels which produce keep on growing the follicles, but it would not be perceived at the level of the hypothalamus. So there'll be a prolonged depletion of the endogenous receptors at the hypothalamic level. So as a result of which there is multifollicular growth, and as a result of which there's a risk of multiple pregnancy and OHSS. Unlike what letrozole does is it is an aromatase inhibitor. So since it is decreasing the estrogen and hence by negative feedback again increasing the FSH. However, the major difference is that it has a shorter half-life of 45 minutes and that chronic depletion of receptors is not happening. So there'll be a monofollicular rise of this FSH, as once the hypothalamus senses the estrogen rise, it will inhibit the FSH rise, and therefore it is because of a monofollicular growth that it is a preferred choice of a drug in ovulation induction. Secondly, it also has anti-estrogenic effects, as we discussed earlier, on the cervical mucus as well as on the endometrium, which helps in the increasing of endometrial thickness, increasing the blood flow, and hence also improving the pregnancy rates. So we'll go one by one. Like first, we'll discuss about IUI and PCOS, how letrose is helping us. So we all know that Cochrane Database Systemic Review came in 2018, and it actually proved that letrose is the right choice of ovulation induction agent for women with PCOS. By that, there was a high quality evidence which showed that live birth rates were quite higher with letrose as compared to clomiphene in timed intercourse cycles. Secondly, we see that in 2018, a European journal was publishing an article which was retrospective, and it was regarding ovulation induction and IUI, wherein they used a comparison of drugs, letrose, clomiphene, and gonadotropins. So in total, there were 1068 cycles which were studied, and their primary outcome was live birth and the multiple pregnancy. So this table here shows that they studied both the monofollicular growth and the multifollicular growth of the follicles, and the primary outcome being clinical pregnancy and live birth rate. They found out that the monofollicular growth of the follicles, either with CC or letrose, there is not statistically any significant difference we are finding in the rate of pregnancy, whether it's clinical pregnancy or multiple pregnancy. So they concluded that since multifollicular growth is just increasing the multiple pregnancy rates and without increasing the overall live birth rate for patients, so ovulation induction would strictly aim at monofollicular growth. And we all know that the monofollicular growth, the drug of choice would be letrose, and it was proved by the study as well. Another study which was published in 2019 European Journal was a randomized control trial, which was also a comparison of two drugs, again clomiphene and letrose in PCOS patients, and they had studied the pattern of endometrial thickness and the blood flow, which was helpful in showing whether the pregnancy rates are related with the increased thickness and the flow index of the endometrium. And this study proved that the clinical pregnancy and the ongoing pregnancy in letrose group is significantly higher as compared to the clomiphene group. And this was probably because of the increase in the endometrial receptivity compared of letrose with CC when it was seen in PCOS women. Coming to the second part, that is ovulation induction done with letrose in minimal and mild endometriosis and followed by IOI. So there's an abstract which was published in 2012 in Obstetric Gynecology Journal, and it was regarding a randomized control trial which followed a consort criteria. And here they tested around 136 women with primary infertility who had undergone surgical treatment for minimal to mild endometriosis, and they were unable to conceive naturally for the next 6 to 12 months. So they subjected them to ovulation induction and IOI, and they divided it into two groups, again with letrose 5 milligram and then clomiphene citrate for 100 milligram. What they actually observed was the clinical pregnancy rate and the cumulative pregnancy rate for next 4 cycles of ovulation, IUI. So they found out that though there was not a significant difference between the clinical pregnancy and cumulative pregnancy rate in both the groups. However, if you see that letrose is having the cumulative pregnancy rate being higher, 64.7% versus 57.2% in the letrose group as compared to the clomiphene group when they were compared. Use of letrose in unexplained infertility and IUI. So there was a journal which was published in International Journal of Reproductive Biomedicine in 2017, which was a randomized control trial, and it was done on 180 infertile women who were suffering with unexplained infertility. It was done in Iran, and the first group, they had given letrose for 5 days, and another group, they were given 100 milligram of clomiphene for another 5 days, for the 5 days. So both the groups of 90 patients, they were adding in another drug, which was a gonadotropin. So many times what we do in IUI is we either do letrose or clomiphene, or we combine it with a gonadotropin. So this is the addition of gonadotropin for both, and we had a strict cancellation criteria for this also. And if that more than 3 follicles were seen at the time of trigger, the cycle was cancelled. Moreover, if there was a tendency that the women were having 15 or more follicles on the start of the cycle, they were thinking that they would go towards hyperstimulation, so they were not taken as the participants again. What they observed in this was that the rate of clinical pregnancy as well as the positive beta HCG was comparatively higher. It was significantly higher in the group where HMG was added to letrose as compared to when HMG was added to the clomiphene group. So they also observed that the endometrial thickness was also higher at the time of HMG administration in letrose group, which we already know, and OHSS was significantly higher in the clomiphene group. Coming to this,
out of time.
So we're talking about, this is the last slide. this is the comparison of this is a meta-analysis basically. So there was a meta-analysis done in 2019 and again in 2020. Almost 4 of the RCTs are similar, and both of these are actually based on the primary outcome as total pregnancy rate. So we see here they had a forest plot, and they came out to a conclusion after these 4 studies were studied and they come to a meta-analysis. They came out to the they came out to the conclusion that the total pregnancy rate, whether you give letrose or whether you give clomiphene in an IUI cycle for unexplained infertility, there is no significant difference present. At the most, there is only improvement of a dominant follicle and reduction in the miscarriage rate when you use letrose and compared to clomiphene. However, for total pregnancy rate for either of the 2 medicines, it hardly makes any statistical difference. So similar meta-analysis, as I told you, is having the similar RCTs. The 4 of the RCTs are similar, and they have included another 4 RCTs in 2019 meta-analysis as well. So this also, however, had a little limitation that it was having a lot of heterogeneity of data between these studies. Although the results were similar, that they also did not show any significant difference in the clinical pregnancy rate between both the groups. So I would like to conclude that, however, till date, there's no strong clinical guidelines recommended that what is the actually preferred drug in IUI cycles. Like, okay, this IUI is for PCOS, or this is we are doing for unexplained infertility, or as a journal, what exactly are we going to follow as a prototype? Like, we are always going to do letrose, or we're always going to do clomiphene. So there's always a combination of drugs people are following, doctors are following. And I think, yes, there is no strong clinical guidelines still which recommend any of the preferred drug. Thank you.
Thank you so much, ma'am. Over to Dr. Yuvraj sir now to prove that your drug is actually better in next 5 minutes, and then we'll have a debate over.
Hi, good evening, everyone. Is my slide visible?
Yes, sir.
Yes, sir. Yes, sir.
Yeah. Good evening, everyone. Thank you, Niharika, Priyankur, and YTP committee for inviting me for this debate. And thank you, Chaitanya sir, for the kind introduction, and my good evening to all the seniors here.
So you are not audible.
Talk on CC versus. Hello.
Yes, sir. Now it's audible.
Kindly just check your.
Hello. Yeah. So my first reaction, of course, was, I'm not going to find too many support for clomiphene citrate, and because we've all started actually blindly using letrozole, and as Dr. Parikshit Tank also told us, we've not really gone into the literature of is there really enough evidence. And thank you, Dr. Akriti. It was a wonderful presentation, but I think her last slide sort of said it all. For clomiphene and letrozole being a debate with the wide use of letrozole and our blind use, the fact that if we can still say that we don't have enough data and clomiphene still stands a chance, I think it's or can be. So as I said, I thought this is going to be like a one-sided debate where, of course, Akriti was supposed to have all the advantage, but luckily, when I try to go into the, you go by your experience and you go by what you've used so far and what works for you. So we'll come to it later on. Of course, a brief introduction, Akriti has already given, Dr. Akriti has given the introduction of clomiphene and letrozole and its mode of use. Of course, it's an anti-estrogen used for ovulation induction. We have these many options. But, first anti-estrogen therapy was approved in 1967. We've been using it for ovulation induction for more than 45 years. That itself is a little bit of hope, and it's a little bit of proof that this drug somewhere works. I especially got this paper, which is like, in the 1960s and 1980s, there were papers being published with clomiphene citrate, right? So that somewhere proves that the drug was acting. And suddenly now we've got into this blind race of using letrozole everywhere. Of course, it is a SERM. It binds to estrogen receptors and has tissue-specific effects that allow them to function. The mode of action of clomiphene citrate, I think all of us know, so I'm not going to go into the details. Now, I decided, how do you decide whether clomiphene or letrozole or letrozole is better than clomiphene. I think for all IV normal groups, poor responders, normal responders, and hyper responders. Normal responders, hyper responders. When you talk about hyper responders, you kind of go back and you kind of lose the battle. You feel that clomiphene might not have any use in hyper responders. PCOS patients, hyper responder patients, letrozole is supposed to be the drug of choice. Actually, that's true. But if you act, and Dr. Akriti actually gave this Cochrane review and she quoted it. But what I would like to bring to your notice here is live birth rate and pregnancy rates were higher. But if you see the quality of the evidence, it is still moderate. We are still not in the phase where Cochrane is able to say that it is highly recommended. We still somewhere go into the range of moderate quality evidence. And the same Cochrane review, which was, just showed to us being letrozole a better. We all talk about letrozole in terms of, OHSS come hoga, miscarriages rate come hoga, multiple pregnancy rates are going to be lesser. But you see this same Cochrane review, which has 42 RCTs and 7,935 patients, it actually showed that with proper use, right use and legitimate use of clomiphene citrate, there was no significant difference in OHSS, miscarriage rates, and multiple pregnancy rates. And this is the same study that Dr. Akriti had put forward. I think even in PCOS, we still have a little bit of scope for clomiphene citrate. Now, when you come to normal responders, again, if you take 5 studies, one study will show it has a better live birth rate. Second study is going to show it doesn't have a better live birth rate, but it has a lesser bit of an abortion rate. Third study is going to show all the pregnancy rates and live birth rates are same, but multifollicular rates are important. But again, if you come to meta-analysis, and these are meta-analysis of 2020 and 2029, if you will try to see, it has clear that there is still no difference between the two groups in the total pregnancy rate, endometrial thickness, and pregnancy per cycle rate, and also importantly, multiple pregnancy rates, which we all have been, we have all been blindly, even me today, I was also surprised while making this so-called presentation. I thought clomiphene citrate, multiple pregnancy rates, higher rates of miscarriages, bad endometrium. To actually go into the data, RCTs and multi-analysis or meta-analysis don't really support it. Again, New England Medical Journal, letrozole, gonadotropin, and clomiphene, all 3 were kind of compared by them. And if you read the conclusion, in the women with unexplained infertility, ovarian stimulation with letrozole resulted in significantly lower frequency of multiple gestation, but also a lower frequency of live birth as compared with gonadotropin, but not as compared with clomiphene citrate. Right. So indirectly, A was equal to B and B was equal to C. So A was equal to C. Again, ASRM review 2017-18, all have said clomiphene citrate still holds a role. So unexplained infertility, clomiphene is almost equal to letrozole. PCOS patient, we still do not have enough data. And now coming to poor responders. Poor responders, still all of us or majority of us, somewhere or the other, still try to use clomiphene citrate. We want that extra push of FSH. We want somewhere in poor responders to have that multifollicular growth, whether it is an IUI or an IV. And again, you will find multiple papers on ovarian stimulation with poor responders with clomiphene citrate. In fact, that itself formed the basis of minimal stimulation and mild stimulation, which has gone, especially in Asia Pacific countries, have been accepted in huge levels. And complications was one of the important things again. So I've already discussed, talking about complications, the most recent Cochrane data doesn't show any significant difference in PCOS patients. Now remember, this is only for PCOS patients. So unexplained infertility, normal responders and poor responders, I don't think we need to be worried about. In cases of OHSS, miscarriage and multiple pregnancy rate. The only thing I need to point out here is they have clearly mentioned that it has to this happens only by the right use of clomiphene. So you should know when to cancel the cycle. You should know whom to, with what dose to actually adequately stimulate. To conclude, letrozole is new, it's modern, it's good, we all agree. But at the same time, do not forget that the old and traditional still holds place, and we still need enough, say that it is a lap-sided win. Thank you so much.
So the last slide was very
to comment. And yeah. Shembika sir, can we have your comments over this?
Yeah. I'm not a judge, right? I am just an expert. So I am not supposed to give the result, but I must say that it is all nicely explained by Akriti and Yuvraj, of course. And Yuvraj, you must have thought that this is not a good topic for discussion initially, because whenever we talk about CC versus letrozole, it is always a letrozole which has an upper edge over CC. But then at the end, you have nicely explained the importance of clomiphene citrate. Actually, clomiphene citrate is an age-old drug. It is available since 1960. But nowadays, nobody respects age unless it is distilled and bottled. And CC is neither distilled nor bottled. So, क्या CC को lifetime achievement award देने का वक्त आ गया है, या फिर CC is here to stay? So that is a question. But I must say that one thing is sure, that letrozole के साथ जो controversy हुई है, we all know it was banned at once upon a time. That never happened with CC. It was never banned, and it never went into disrepute. So if you just look at this comparison, you must, and you have Yuvraj nicely explained the various indications like diminished organ reserve where CC has still role to play. So the slides, Yuvraj, your slides were really nice. Akriti, you have also explained the things very nicely. And I think finally the take-home message is CC is here to stay and still has a role to play in ovulation induction. Thank you so much. Thank you.
Absolutely brilliant debate, I think. And we have like a whole panel discussion ahead of us. We are going to discuss. I think everybody should unmute themselves and be on video. So we have the panel discussion that is optimizing IUI outcome. The moderators will be Dr. Aditi and Amrita Tandon ma'am. And both of them are basically obstetrician gynecologists and laparoscopic surgeon and specially fertility specialist in the Sudha Tandon Fertility IVF, Mumbai. And our panelists are none other than Dr. Sharmila Ayo ma'am. She is the Vice President elect of FOGSI, past Chairperson, Clinical Research Committee of FOGSI and ICOG Governing Council 2021-23. We welcome you, ma'am. Dr. B. Kalpana ma'am. Ma'am is a gynecologist and fertility consultant at Guru Hospital with the Secretary Moggs and Founder Secretary Madurai Chapter of Tapisar, MCOT and National Coordinator of Infertility Committee FOGSI. We welcome you, ma'am. Dr. Rituparna Das ma'am. Ma'am has done a fellowship in reproductive medicine and is a consultant reproductive medicine at the Ramakrishna IVF Center, Siliguri, and has received a formal training from the NOA IBI Spain and advanced course from the IRR Kolkata. We welcome you, ma'am. Dr. Sulbha Arora ma'am. Ma'am is a clinical director and senior consultant in the NOVA IVF Fertility Andheri, Mumbai. Is practicing a gynecologist IVF specialist for last 18 years with the ex-scientific director in the Rotunda Blue Fertility Clinic and Keyhole Surgery Centers. Dr. Rajul Tyagi ma'am, we welcome you ma'am all the way from Lucknow. Ma'am is a founder director from Javitri Hospital and is most famous infertility specialist in one of the most in Uttar Pradesh. She has completed her medical and obstetric qualifications from KGMC and has been trained in fertility abroad. Dr. Ruchika ma'am has done the MD FICOG MRCOG Part 1 and the professor of the Department of Obs and Gynae in the SNMC Agra and is a joint editor journal of the SAFOG and is an editorial board member in the SAFOG and JK Science, Secretary Indian Menopause Society of the Agra Society. We welcome you, ma'am. Dr. Himanshu Roy sir is the consultant in the Shrijan Fertility Clinic Private Limited, Patna, and has done the first IVF baby of the Bihar in 2003. Has published over various chapters and papers. We welcome you, the whole panelists. And this is going to be a very jam-packed session. Now I hand it over to Dr. Aditi and Amrita ma'am.
Thank you, Manisha. And at the outset, I would like to thank Niharika and Priyankur and, of course, YTP for this opportunity. We have an expert group of panelists in front of us, and we also have a lot of seniors and people on the on the webinar. So I think we're going to have an excellent session. And today's panel is going to be focused on improving IUI results. And I request all the panelists to be very practical in your answers and tell us that what you actually practice in day-to-day, because IUI is one of the most commonly performed ART procedures. So moving ahead, we'll straight away go to the first case. So this couple comes to your fertility clinic. The wife is 28 years old. The husband is 32 years old. They've been married since 4 years. They're trying to conceive since 2 years. And as such, everything looks okay. The ultrasound is normal. Her cycles are regular. Frequency of intercourse is fine. AMH is 3.4. Her sperm count is okay. Her HSG shows that the tubes are patent. And she has had 2 cycles of ovulation induction with clomiphene and timed intercourse at another center. And the ultrasound shows that there was a ruptured follicle, but she has not conceived. Now she's come to you. So Dr. Sharmila, I would like to ask you the first question. What would you do and how would you counsel this couple further?
This will be like unexplained infertility. Everything looks normal. The couple, I think, married for 4 years and every factor is normal, and 2 cycles of ovulation induction done just for the sake of it, because she's got regular cycles and has got no sexual dysfunction. So the counseling should be like for every part of like, because unexplained infertility, we cannot give any results without like starting with the treatment. There's nothing like a prospective thing to tell how, like what is that method which will make her conceive and all that. So in our country, I think we'll always offer 3 cycles of IUI at least before we go ahead with IVF, because sometimes we have seen that couples have got a sexual dysfunction problem, which sometimes they are not aware of also. So your counseling should be like talking about the sexual problems also, because husband stays in one place, wife stays somewhere, and sometimes the jobs make them not having a proper, what they say may be normal, may not be normal. So sometimes it works also. So that will be their counseling, and give her everything prospectively. Don't give her like blank statements like you will conceive in this many months and all that, because in an unexplained infertility, nobody knows what's going to happen.
Fair enough, ma'am. Point well taken. Suppose you were to go ahead with an IUI for this couple. Dr. Kalpana, I would like to ask you, what protocol would you use for controlled ovarian stimulation?
Was she stimulated previously?
She was just stimulated with clomiphene 100 milligrams in 2 cycles, and that was along with timed intercourse. So she has not received any other sort of stimulation or IUI previously.
I just want to know about the previous details, whether she ovulated with the clomiphene straight milligram, and what was the endometrial thickness? Was it good? And even then, if she has failed in those 2 cycles, I would like to know about her BMI also, and testosterone level. So if she's obese, I will BMI more than 30. I would like to add on metformin or other insulin sensitizers. But if everything is fine, she has ovulated, endometrium is fine, even then she has not conceived, means I would like to counsel her the possibilities we have, either what is her age you told?
She's 28 and she has good AMH. She's AMH of 3.4, and assuming that every other thing is normal, her endometrium was good in the previous cycle, she did ovulate with clomiphene. BMI is in the normal range.
So we can think about moving on to gonadotropin for this patient, because she has not conceived with the previous 2 cycles, even though everything was normal, endometrium normal, ovulated, but she didn't conceive. So I would counsel the patient the possibilities we have, and then I would advise gonadotropin for this patient, because as we all know that the pregnancy rates, when we compare with the clomiphene side rate and adding on to gonadotropin, will definitely improve her pregnancy rate. That's
sure,
what.
So can you please elaborate on what type of gonadotropin you will use and what would be the dose? Would you give her daily gonadotropins or would you give her alternate injections? So
Yeah. As far as the type of gonadotropin is concerned, even recent evidence, ESHRE guidelines also concluded that there is no great difference in pregnancy rate when we think about urinary gonadotropin or recombinant gonadotropin. And, definitely, recombinant gonadotropin in IUI cycle is not going to be really cost effective. So urinary gonadotropin is always better when we are thinking about cost in patients who are going for IUI cycles. Type of gonadotropin is not going to change her success rate. So we need to counsel the patient about the options and
what would you use in your practice? Like,
yeah,
if this test, what you are going to use?
Yeah, generally I go for HMG. Alternate day. We can use daily for 4 days, but not for almost all the days of stimulation because it is not going to be cost effective. So alternate days, combining letrozole with gonadotropin for day 2 to for 5 days, we start letrozole on day 2, then add on gonadotropin probably on 7th day, 9th day, and then rescan her on 9th day. Depending upon her response, if needed, we can add one more dose of gonadotropin. But if she is more than 14 millimeter, I don't think we need to stimulate her further. She would probably grow spontaneously. And then we scan for optimum maturity. Once she reaches 18 millimeter, then we can go for trigger. And if male factor is normal, timed intercourse is okay. If it is borderline, then I would suggest her for IUI. Again, I would counsel her the options. We have single or double IUI, even though both these will not change her success rates. If she's for one IUI, probably after 36 hours, I would go.
Yes, ma'am. We'll get there. We'll come to that discussion in due course of time. So, Dr. Rituparna Das.
Amrita, can I add just one point?
Yes, yes.
ESHRE is very clear on that. The stimulation protocol does not matter even for unexplained infertility. You need not go for gonadotropins because gonadotropins are known to cause multiple pregnancy. It is equal to the success rate which gives also. So be very careful.
My next question: does anybody differ and
don't combine both? Don't combine both. That's what ESHRE says because they say the results do not matter at all when you combine both.
Yes, if we could have the next slide, Aditi. Yes. So when according to ASRM as well as ESHRE, like Madam said, when you compare clomiphene or letrozole, the results for when you the outcome of live birth rate is counted for unexplained infertility. Both are comparable. Next slide, please. So letrozole also gives no significant difference in pregnancy rates or multiple pregnancy rates with letrozole as compared to clomiphene. So both are superior to expectant management. And gonadotropins as such are not indicated or recommended for the treatment of unexplained infertility. Oral ovulagens work well enough, so this should be the take-home point. But of course, in our practice, we may practice differently. So this is why there could be a debate amongst the panelists as to what they actually do.
Yes. Yeah, this is what we want to highlight also because practically also because of the adverse effects of clomiphene, we are starting with letrozole only in most of the patients.
Right. Dr. Rituparna, how would you monitor an IUI cycle? Would you
suppose this patient, she's coming for the first time to me. So I'm going to give her letrozole and no gonadotropins, call her on day 8 and day 9 and see the size of the follicle. If the size of the, maybe for the first cycle, I will not be adding any gonadotropin, just see her that how she's responding because in previous cycle also she has good ovulation was seen. So for the first cycle, generally, I don't want to burden the cost, so not at the cost. So I'll be giving letrozole and call her on day 8 and day 9. and then maybe again a next scan when the follicle size is 18 to 20 mm, and then give her trigger accordingly. Now, suppose if she fails in the first cycle and then the next cycle, yes, maybe then I can add a gonad drop-ins and then call her, usually for IUI monitoring, call her day 8 or day 9. And when the follicle size is 18 to 20 mm, and for clomiphene citrate, definitely the size should be more, is from 20 to 20 mm. And of course, see the endometrial thickness also, that is also very important. And then give the trigger.
Fair enough. So point well taken, Dr. Rituparna. Next slide, please. So as she said that with oral ovulogens, you can go up to 22 mm, but with gonadotropins, you probably stick to 18 to 20 mm. And would you also do a color Doppler? Dr. Sulba, can we have your views on this? For an IUI cycle, would you do
No, I don't usually add color Doppler for the IUI cycles. There are some studies which say that analyzing the flow in the endometrium or even in the perifollicular area does tell you a bit about the prognosis, but I don't routinely do this for IUI.
Yeah, so does anybody on the panel use, color Doppler as a routine for measurement of the perifollicular flow and the RI and the PSV to know whether the patient is ready for the trigger? I just want to have a debate amongst the panelists.
So difficult to do, Amrita.
Right. So studies do say that the PSV of the perifollicular vessels should be more than 10 and RI should be between 0.4 to 0.48, and this probably would increase the the success rate. But yes, in practicality, it may not be done by everybody in each IUI cycle. So
every time you listen to Dr. Sonal Panchal, you feel like doing, then you stop it after 2 days.
In fact, they talk about the 3D ultrasound as well. So
the point is, if you don't find the parameters as they should be as per these criteria, are you really going to cancel that IUI cycle?
Absolutely.
If it is going to make no impact on your management, then why do unnecessary tests that are not going to change your line of treatment?
It's like sorg. It's like grapes, the fox and the grapes. It's too sorg.
Even for IVF cycle, it is really difficult to assess the sensitivity with Doppler. So IUI cycle, I think it is not possible.
Okay, Dr. Aditi, would you?
Yeah. So at the outset, I would like to thank Dr. Niharika, Dr. Priyankur and Team YTP for giving us this opportunity. Continuing with the questions of the panel, I would like to ask Dr. Himanshu the next question. So what would be the choice and the dose of your trigger?
The trigger that we normally use is 500 international units of urinary HCG. That is the most common. If we are thinking that there might be more than 5 or 6 follicles, then sometimes we do go for decapeptyl also for GnRH agonist. But usually, mostly we've done with 5,000 units.
5,000 units.
Yeah.
Okay. Would anyone on the panel would anyone on the panel like to give recombinant HCG?
Yeah, no. I do give recombinant SVG sometimes instead of 5,000. Sometimes I give. Yes, I give.
And what is your rationale behind it?
Yeah, last year during the COVID time, we did a study on HCG 5,000, HCG 10,000, and recombinant HCG also. And there were like around 50 to 100 patients in all the 3 groups. What was interesting that in the recombinant HCG group, we found the level of HCG on the day of IUI was highest. It was around 120. In the group of the patients in which we had given 10,000 units of HCG, it was around 90 or 100. And in the group where 5,000 was used, the level was around 75 to 80. So, but interestingly, the pregnancy rates were same in all the groups. And when we saw that whether the follicles ruptured on that day or next day or not, so it was equally good in all the 3 groups. So the only thing different was the level of HCG, which was highest in the recombinant group, lesser in the 10,000 international unit group, and it was lowest in the 5,000, but it didn't make any difference to the clinical outcome.
Right. That's what the studies also state, that whether you use recombinant or urinary HCG does not matter. The pregnancy rates are similar. How about the timing of the IUI, and would you want to do a single or a double IUI? Dr. Ruchika?
Yeah. So if it is a natural cycle, then after 24 hours of the LH search, I would go for an IUI, or otherwise 24 to 40 hours after this HCG administration, after HCG trigger, around 36 hours of HCG trigger, we'll go for IUI. And preferably single IUI, because evidence does not support double IUI, because clinical pregnancy rates are similar whether we go for double IUI or single IUI. So I would like to go for single IUI, and maximum number of what the evidence says is maximum IUI we cannot say, but minimum at least we should counsel the patient in advance that minimum 3 IUIs should be done before we we should not give false hope to the patient that in first IUI cycle itself you will get conceived. So we have to tell the patient from the beginning that minimum we are going to do it for the 2-3 cycles.
Right.
And maximum up to 6 months we can do before going for IVF because of cost effectiveness, cost constraints in our country.
Right.
Can I add something here?
Yes, madam.
So firstly, about the timing of IUI, yes, we have been doing at 36 hours for a long time, but now there are more studies that show that delaying the time between the HCG trigger and the IUI actually can increase the pregnancy rates. First of all, see what happens in a natural intercourse. The sperms are all going and getting stored in the cervical crypts. There's a reservoir there. But here we are putting the sperms directly into the uterine cavity, and then they're going to perfuse into the fallopian tubes and be gone. They don't have a place where they can wait. So if you do the IUI at around 40 hours, and there are now papers that say 48 hours after the trigger, then you are doing it just post-ovulation, where the chances of pregnancy might be higher because these sperms are already capacitated. They don't even need to undergo those 6 to 8 hours of capacitation in the genital tract. So doing it post-ovulation is better than doing it pre-ovulation. If you call your patient at 36 hours, in a lot of cases, she might not yet have ovulated. And then we are in a dilemma. Should we do it? Should we repeat the trigger? Should we call her the next day? If you call her the next day, it may be too late. So instead of 36, extending it to around 40 or a little more than 40, it might actually help. And the second thing is about the number of IUIs maximum that you will offer. Also, there are studies that show that if you look at the pregnancies that took place after IUI cycles, 90% of patients will tell you after 3, and 97% patients will tell you after 4. So there is barely a 3% patients who will benefit with any further IUIs after 4 IUIs have been done. So 3 to 4 maximum is what I would stop at.
Absolutely.
Then,
and
can I add one thing, a flip side to this thing of 40 hours? There has been studies now which are coming in which you give HCG and do IUI at the same time. Especially for women who are coming from outside and they don't have time, you can do both the things simultaneously. And in the studies that have come, they have given the same pregnancy rate. We have tried doing that, but the patients are not convinced because there's so much, they have been fed this thing that ovulation will take after 36 hours. So it takes, with the range of ovulation after HCG trigger is 18 to 53 hours. And the median is 36 hours. That's the reason why we have been all doing it at 36 hours. But if the sperm quality is not very compromised and you give inside, put it inside the uterus, they will remain in the genital tract for even 6 to 7 days. So whenever ovulation will take place, that reservoir will take care. So that is just one of the things that has come recently. That give HCG and do the IUI on the same day. Don't call the patient will be saved from coming twice to your clinic, and they will be saving time without compromising the pregnancy rates. But more studies are needed on this.
That's a good point.
For 2 IUI, I think 24 hours and 48 hours would be ideal, and it is easy for us, for our practice also. Calling them at 36 hours, documenting ovulation, and then because post-wash sperms usually capacitated for 2 hours. So it would be ideal, even though the pregnancy rates are not increased with the double IUI, 24, 48 will be convenient for the doctors.
So the Cochrane database says...
I was very surprised to find that whenever I did the trial of 2 IUIs and documenting ovulation, my pregnancy rates went down. So I started that thing when I started my practice, and again during COVID times when we had time to follow the patients and the patients also had time. But rather than increasing, it decreased the pregnancy rate. So maybe it's stress part or so much functioning, because you know that many things change when you observe them very minutely. So I don't know about that, but I have got very poor results with double insemination and documentation
So
of
we,
ovulation.
so in fact, as a substitute to that, I would like to suggest that we can do single IUI and then ask the patient for natural coitus in a span of.
So yeah, so I wanted to just add that point that sometimes when we find that the follicle hasn't ruptured, first of all, that is no proof, confirmatory proof. Ovulation might have occurred, but the follicle still reforms. But those are the cases where we ask them to go home and additionally try naturally, because in case it's going to still rupture. However, there are cases where the couple absolutely has no natural intercourse at all. There are cases of non-consummation. In these cases, there is no way you can tell them to go home and try. They are not going to go home and try. So in those selected patients, you can probably do a double insemination just to give them the benefit. And the Cochrane database also says that there is a role of double insemination in cases of borderline male factors. So in maybe those cases, we can think about it.
But why an unnecessary ultrasound to confirm ovulation when you're given?
It is actually not required. You're right, ma'am. It's actually not required.
Right. So if you, Dr. Sulba, if you see that it is not ruptured, do you give a repeat trigger?
I don't actually. We used to, but now there is more evidence that says that, in fact, even as Dr. Charmila said, that documenting ovulation isn't even required. The only proof of ovulation is pregnancy. Right. So I don't repeat the trigger now. Yeah.
So let's look at what the evidence says. This was an IUI review article in Human Reproduction in 2019, and it basically said that single IUI should be performed anytime between 24 to 40 hours after the trigger, and there is no statistical difference that a double IUI increases the pregnancy rates over a single IUI. And also there was insufficient evidence to recommend maximum number of treatment cycles. However, at least 3, like Dr. Sulba mentioned, should be performed. All right. So moving on, if on the day of trigger, if you see that the endometrial thickness is just 5 mm with no vascularity, what would you like to do? Dr. Rajul?
Is Dr. Rajul ma'am with us on the panel?
Okay, any of the panelists can take this question.
There's no point in giving any adjuvants, Aditi, because if only the follicle is good, the endometrium is going to be good. That's the basic point. The second point is endometrium per se, maybe a peripheral defect also can be there. So adding an adjuvant at this point of time, at the time of trigger, is not going to help you in any point, and it will give false hopes to the patient who's going to spend a large amount of money for the IUI also in small centers. So I think once you see a thin endometrium and there's no flow, it's better you go back and reevaluate what you've done with your protocols and any other factor you've missed in the patient, the reason for the thin endometrium. Other than that, adding an adjuvant at this point of time may not help her at all.
Yes, ma'am. My question was adjuvant for the next cycle, but if you see 5 mm endometrial thickness, would you cancel the cycle or would you go ahead and do the IUI?
Cancel the cycle.
I will not cancel the cycle.
I would rather cancel.
Natural try.
Instead of IUI, she can go for a natural cycle.
Yeah. Even pregnancies have been documented with 6 mm endometrium also, even though it is not sufficient. But instead of cancellation, I think natural try would be better. But on the day of trigger, identifying 5 mm is, we could have identified little earlier on the 9th day or 10th day when the follicles are almost 12 mm and 14 mm, when the endometrium is not synchronous. At that time itself, we need to counsel the patient that the endometrial growth is not sufficient, and we may cancel IUI and we may go for natural try. That should be the counseling given prior to trigger, so that she will be mentally prepared for that, and she will not be upset on the day of HCG.
Right. And anyone would like to add any adjuvants if during this course of stimulation you notice that the endometrium
So if I see that the endometrium is thin by the time the follicles have already reached 14 or 15 millimeters, I add vaginal estrogen at that time. And giving those 3 or 4 days of vaginal estradiol valerate, I see a very good endometrium by the time we come to trigger or by the day of IUI. I usually don't add other adjuvants in an IUI cycle. As the other panelists have said, if it continues to remain thin, we can probably convert it to a planned relation cycle rather than making them spend the money. But yes, pregnancies have been documented with even less than 5 millimeters. The more important thing is that it should be a trilaminar pattern. Then it is a healthier endometrium.
Yeah, the
I would like to add a word about PRP, platelet-rich plasma, and it has a definite role in cases of thin endometrium, and it's very easy to make. So we can go for that also as an adjuvant.
Yeah,
if the endometrium is persistently thin, then we need to think about some endometrial pathology.
Yeah.
And then we need to plan the treatment. If it's a single cycle because of clomiphene, we can change the stimulation protocol. But if it is some pathology in the endometrium or prolactin level should be checked if it is thin. If it is normal, then hysteroscopy should be done to rule out endometrial pathology. Then we need to go back and study her previous cycles also.
Yeah, madam, I'd just like to add one thing, that thin endometrium of IUI is not the same thin endometrium of IVF. Because in IVF, we stimulate for more number of follicles. So it is a very, very super hyperestrogenic environment. So in that circumstances, if you have got a thin endometrium that is more pathological than in cases of IUI where you have only 1, 2, or maybe 3 follicles when the estrogen levels are not as high. So the thinking of thin endometrium of IVF should not be extrapolated to the IUI cycle. And in IUI cycle, it has been shown that even with a thinner endometrium, pregnancy rates are not compromised, and you will be denying the patient the chances of pregnancy of that cycle. So you have planned, and even if you've got 5 mm or 6 mm, you should go ahead and do the IUI rather than cancelling it.
Right. And in a lot of cases, it's simply because of the clomiphene, if clomiphene has been used.
That's right. So yeah, that's exactly what this review article and meta-analysis says in human reproduction, that there was no evidence between the endometrial thickness and pregnancy rates during an IUI ovarian stimulation. So cancelling the cycle because of a thin endometrium may not be necessary. You can go ahead and do the IUI irrespective. And of course, you, as all the panelists have mentioned, stimulation protocols need to be seen, and the patient will also give any history of a myomectomy or septal resection or other endometrial pathology. And we've also spoken about the adjuvants. Amrita, would you like to continue?
Yeah, I think this topic has been discussed in depth during the previous lecture. And I mean, does anyone else wish to add anything or do a hysterolaparoscopy in this patient, in this particular patient at this point of time? So maybe you've done 3 cycles of IUI in this patient of unexplained infertility and she has not conceived. Would you wish to do a hysterolaparoscopy?
See, if 3 IUIs have failed and you need to counsel the patient about 2 different options. One is moving on to IVF, but if she's not keen on IVF, if her ovarian reserve is still good, if the semen analysis, semen parameters are good, then you can consider doing a hysterolaparoscopy before moving ahead.
Fair enough.
If the patient's endometrium is thin, definitely we need to go for hysterolaparoscopy. And also, if it is unexplained, we don't have any reason for her infertility. If it is unexplained, then we need to rule out endometriosis also. In that occasion, definitely we need to go for hysterolaparoscopy.
Yeah, so there is a small role of hysterolaparoscopy, but it has to be specific for that particular patient, and all the causes probably need to be looked out, and maybe you can consider it for the patient, whether she would do better with the hysterolaparoscopy or whether you can go ahead with an IVF treatment for her.
If she has got a thin endometrium, I think it's better you go. Other than that, you think twice before going for that.
Yes. Dr. Sharmila ma'am, what if this lady was 38 years old? She comes to you with the same history, but she's 38 years old now.
See, in my part of the place, they will not accept IVF the moment I say. So here, practically what we do, any patient who comes, we offer them IUI for at least 2 to 3 cycles, see at least how the protocol works for them, how the endometrium grows, how the follicle grows. And by the time they get fed up and they only ask for IVF by that time, because if you offer IVF, they will move on to the next hospital. That I'm very clear here. So my practice is I offer IUI even if she's more than 35. at least for 2 to 3 cycles. Unless she asks, then I go straight away for IVF, because we know that IUI is not going to give great results beyond 10% for any patient. And with a person who's having a lower ovarian reserve, it's not going to help you much. The cost factor becomes almost equal with that way they travel and all that. So you give them all the options. If they accept IVF, I would rather go for IVF. She's not accepting, or if I feel she's reluctant, I will offer her 2 to 3 cycles of IUI and then take a call on that.
Does anybody have a difference of opinion for this particular point?
No, that's exactly what I would do as well. Give her both the options, explain to her the chances with IUI, the chances with IVF, and explain to her that percentage of aneuploid oocytes is likely to be high at her age, and then let her take a decision, keeping in mind the cost factor.
Right, absolutely. Thank you. So basically, we know that typically 3 to 4 cycles of ovulation, ovarian stimulation with IUI with oral agents is good enough for a patient with unexplained infertility. But if the patient is more than 38 years of age, with good counseling, probably immediate IVF may reduce the time to conception, but that is again a debatable thing. But this is what the evidence says. Okay, so I think we'll move on to the next case. Dr. Aditi, will you?
Yes, so the next case is, I mean, this is one of the cases we commonly see in our OPDs. 31 years old, with a 34-year-old male, married since 2 years, eager to conceive. Wife has irregular cycles. She gets her periods only with withdrawal. Her BMI is slightly high, 28. She has mild acne. Her AMH is 7.5, TSH is 3.2. She has already had 3 cycles of ovulation induction with clomiphene, but there has been no ovarian response. So, Dr. Rituparna, if you could just tell us the difference between clomiphene resistance and clomiphene failure.
So basically, we have only 5 minutes left for the session.
If we're giving clomiphene citrate and patient is not responding, there's no ovarian response, and then we are saying that that patient is CC resistance. But if we are giving, there is a follicle but still not conceiving, then that is called CC failure. So even after giving 6 cycles of ovulatory cycle, they're not conceiving. So for this kind of patient, the first thing will be the lifestyle modification, because her BMI is more and she looks like a typical PCOS patient. But weight loss and lifestyle modification will be the first thing, and then followed by because she has been taking clomiphene citrate for 3 cycles, so letrozole combined with low dose gonadotropins, that I'll be preferring more. And coming to the thing with weight loss, of course, the adjuvants like maybe minestrol, D-Chiro also can be added, also vitamin D that can be added, and before we go for the ovulation induction cycle.
Okay. Yeah, and I would like to add that these metformin and adjuvants like D-Chiro, minestrol, they lead to cycle regularization, and definitely we find a good pregnancy and ovulation rates after these, using these.
Right. So evidence basically says that a 5 to 10% weight loss definitely helps in improving the hyperandrogenism and also making the cycles ovulatory. So lifestyle changes definitely should be the first choice for this patient. And when you compare letrozole versus clomiphene, I think letrozole, especially in anovulatory PCOS women, definitely is the first line management. Yes, Amrita, would you like to continue?
So now, we plan to do a gonadotropin stimulation in this patient with PCOS. So can somebody quickly explain what regimen and what protocol would be used for gonadotropins for COS for IUI in a PCOS patient?
Now, the evidence says that the choice between urinary and recombinant, they both seem to work equally well. And as far as sequential or using only gonadotropins is concerned, using only gonadotropins do have a higher chance of giving us a proper stimulation, a higher pregnancy rate. But along with that, there is a higher chance of multiple pregnancy. There is a cost factor involved. There is a risk of OHSS. So when you give a sequential regimen, where start with oral ovulogens and then follow it up from day 6 with gonadotropins, it brings down the number of injections that you are going to use. It brings down the cost. And it also reduces the risk of having a hyper response.
Absolutely. So Dr. Himanshu, suppose this patient does hyper respond during the course of your stimulation, what would you do? How will you counsel this patient?
Like we counsel on 3 lines. First thing is that we ask them either to convert to IVF cycle. Second thing is to take the responsibility of, take the risk of getting multiple pregnancies and hyperstimulation. And third thing is to just simply cancel the cycle and don't give any HCG or don't give any agonist trigger and just don't have any coitus. So we can cancel the cycle, we can convert it to IVF. So that is the thing that the patient decides. We cannot tell them that what is, what they have to do. We give all the 3 choices and as they want, and definitely we ask them to come for follow-up to see even whatever they choose. Even if they choose of canceling the cycle, still we tell them that if you have pain or anything, like we do a basic hematocrit, we give the prophylactic drugs to them, we give heparin to them, so that, and we tell them that for 7 days you have to observe yourself, and if there is any problem, then you come. Ideally, it's better to convert to IVF because again, we have to tell them that if you plan again for IVF cycle, then it might cost you more. In our center, it is a policy that we offer IVF for half the cost if we are converting a IUI cycle. So many patients take that offer, and if there is hyperstimulation, we freeze and we do it afterwards. So these are the 3 things that can be done.
As Dr. Himanshu said, the best thing is to convert to IVF because the success rates are very high in such cases. They have responded to very small doses. But the only thing is that many a times they are neither mentally nor financially prepared. So it's a good policy when you are starting gonadotropin stimulation in somebody with PCOS to already counsel them beforehand that if this situation arises, you may need to be prepared to convert to an IVF. So they have an idea beforehand.
Yes, so counseling in this patient becomes extremely important at every step of your stimulation.
And if she does not want that IVF, then don't give HCG at all.
Don't give HCG and after not to have coitus.
That's my best thing.
Yes. So Dr. Kalyani has already gone through the low dose, step up protocol. So I think let's not discuss that again. And all of the panelists have given excellent points on use of gonadotropin. Now, what if you see a cyst on day 2 of your scan? So you're doing a baseline scan before starting the stimulation and you see a cyst. How would you proceed?
I would usually give oral contraceptives for a 21-day course and then call her again on the next day to see if the cyst is gone, because it could be a functional cyst. And it's just an IUI. If there is no pressing, sometimes if they are from out of town and they don't really have, they're only here for a month, it's different. But if they are from here and they can take a month of contraceptive and come back on the next day too, then that is usually what we follow.
So that I think is common practice that everybody follows. I think we've already discussed the role of adjuvants. What about insulin sensitizers, metformin? Probably everybody uses it in IUI cycles. If anyone has any...
No. Unless you document a glucose intolerance, we don't give metformin at all. If she's got evidence of insulin resistance clinically, like acanthosis nigricans, I would rather start. But if she does not have any sign or symptom of insulin resistance, we do not give metformin or myonositol.
Okay. And also her BMI, if the BMI is slightly...
Just with BMI, we don't do Amrita. She has to have the symptoms of insulin resistance and signs. Glucose intolerance is there, definitely you will give. But if it's not there, she's got acanthosis, she's got that sleeping patterns of sleeping in the daytime, not able to, those are all symptoms of insulin resistance. There's a checklist for that. Patients have that, then we start them on metformin. Otherwise, there's no need to start even if she's obese.
So maybe
after HOMA IR also we can document there is insulin resistance.
If you document, you can give, but if you don't document, do not give. It may
Yes,
not
although
help
the
for at all.
ASHRAE guidelines do mention starting metformin if the BMI is above 25, and we
Yeah.
also find these women are struggling to lose weight. No matter what they try, they are not able to really achieve much weight loss. But when we add metformin, and now we're seeing those results with the myoinositol also,
Sulba,
it
they
aids
will,
with the weight loss
so
as
Sulba,
well.
No, Sulba, those patients will have evidence of insulin resistance. You will see that acanthosis in most of your PCOS patients. None of them escape that. So you can
No,
start.
madam, it's not sure. I also made a habit of watching for acanthosis, but in many times we encounter lean PCOS and others. Acanthosis is not that common in PCOS patients.
But the lean PCOS
But in lean PCOS, you'll see other signs of hyperandrogenism also. You will see acne.
Otherwise, also in obese patients, many times it's not there.
Yeah. But then
So
I do find that it helps them with weight loss. So
yeah, even one of my patients accidentally, I mean, it's just one patient, accidentally she was taking metformin considering some others, and she had a definite weight loss.
Yeah.
There are people who are taking it for even anti-aging. They're taking metformin for anti-aging. So there are so many indications of metformin.
Yes,
but medical legally, you'll be safe if you document and then start. If she lands up with one rare patient with a problem like lactic acidosis or something.
Yeah. And one of my patients also had symptoms of hypoglycemia after taking metformin. So she said that she fainted. So I just immediately stopped metformin. That's also, you can also encounter.
But then you have to start with low doses and slowly step it up. Then you can minimize these side effects.
Yeah, and it's always should be given along with, meals. So
after
that
a meal.
After
And the sustained release preparations, the side effects are much lower.
Yeah.
Actually, literature evidence is really controversial because Cochrane review 2012 concluded that the ovulation rate and pregnancy rates are increased with metformin. But recent ASHRAE guidelines in PCOS, it can be given, but not routinely for all other patients as a ovulation inducing agent. But in PCOS, we can consider if BMI is smooth. That is the recent literature evidence, I think. We can stop once the patient becomes pregnant. That was the guideline.
Also a new thing that you need to stop once the patient conceives. Yes.
And one thing I would like to know, what is the, dexamethasone, how many of the panelists are giving for a few indications?
No.
As an adjuvant?
No.
Okay. But it has been documented in the literature that those who are having signs of androgen insufficiency can benefit.
Yeah.
Yeah, there are few RCTs when a patient has got CC resistance, especially with the hyperandrogenism, DEXA can be given, but the guideline is not favoring that, has not documented anything about dexamethasone.
Actually, we tried giving after studying Spearoff and all that. It never helped, so I stopped.
Yeah, and as Rishikesh Paiser also said that one of his patients, after 7 days of dexamethasone, developed avascular necrosis of femur. So that also scary.
I think what we're trying to do here is give the audience a good take-home messages,
Yeah.
So maybe let's stick to that. And Aditi, can you please go ahead with the...
Any of the panelists using antagonist in IUI cycles in patients of PCOS?
No.
Not as a routine.
Not as a routine. Okay. And any role of lab ovarian drilling for these patients?
Lean PCOS, thin patients, short period of infertility, having hyperstimulation with your ovulation induction, there is a role of drilling.
Okay. Yeah, so that's
what we do have a question in the chat box. The role of ATT in thin endometrium. Would any panelists like to take that?
Without documentation, do not give AKT. You have to inform the center in your place also. You'll get caught if you give AKT without documentation.
So we need to do CB-NAT of endometrium, and
Culture.
then if it is documented, then we can go
Start
for
it.
ATT, because infection can be a cause.
You have to report to the center. Otherwise you'll get it.
Yeah.
You can't
and
give
infection
like
can be a cause of thin endometrium and hyperechoic endometrium. Many times we see very much hyperechoic endometrium, but only after documentation and proper testing.
Like 3-4 years back, we're giving everybody AKT whenever we had a suspicion. That's all you can't do now. You have to inform the government and then start.
Yeah.
Right. So let's look at what the evidence says. This use of antagonist is only if there are previous cancer cycles with premature LH surge. And of course, like Dr. Charmila said, lap ovarian drilling is to be used for very selected patients, especially with lean PCOS, and those that are not responding to even gonadotropins. I think we do have further cases, but I think we have exceeded the time, so we'll stop here. I'd like to thank all our panelists to give their expert opinions, and on behalf of my co-moderator, thank you to Team YTP for giving us this opportunity.
Thank you, Amrita and Aditi, siblings.
Thank you, moderators. It was an interesting session.
Thank you, Dr. Charmila ma'am, Sulfa ma'am. It was nice to get your inputs.
Thank you, Niharika. She's there. Niharika, thank you so much. Dr. Priyanko.
Yes, ma'am, she's there.
Thank you, Priyanka.
Thank you so much, ma'am. Thank you, Aditi ma'am and Amrita ma'am, for moderating such a wonderful panel discussion. And thank you to each and every panelist. We wish we could carry forward this discussion, but because of our time crunch, we had to cut it short. To end the wonderful webinar that we've had, I would like to call Dr. Priyanka sir from Siliguri to give a vote of thanks. Priyanka sir.
Yeah, thank you. Hello?
Yeah, you are audible now.
Yes, sir.
Hello?
Yes, sir, you're audible.
Yeah, just one second. Hello, am I audible?
Yeah.
Yes, Priyanka, you are audible.
You're muted now.
Yeah, you are muted, Priyanka.
Yes, ma'am. Just 1 second. I think it's better. Yes, ma'am. Yeah, I would like to thank all of you for participating in this wonderful program. It was a endeavor by YTP committee of FOGSI, and I would like to thank YTP committee, Niharika, the chairperson of the committee. She has done wonderful work, and she's organized a number of programs under the banner of YTP over the last 3 to 4 months. And it's indeed been a wonderful program today. It's been a pleasure listening to all of you, all the stalwarts in OBGYN who have talked today. So I would like to first of all thank our FOGSI President, Dr. Shanta Kumari ma'am, Secretary General, Dr. Madhuri Patel, the Vice President in charge, Dr. Basav Mukherjee, and of course, Dr. Niharika, the chairperson of the committee. I especially like to thank our chief guest, Dr. Rishikesh Pai, our guest of honors, Dr. Madhuri Patel, Dr. Archana Verma, and Dr. Rajendra Singh Pardesis for gracing the occasion and for their excellent comments. I would like to thank the chairpersons of today, Dr. Aarti Manoj, Dr. Asha Jain, Dr. Savita Tyagi, and Dr. Sita Ramurthy Pal ma'am for joining us, and also the speakers, Dr. Kalyani Shrimali, Dr. Parikshit Tank, Dr. Sheetal, and Dr. Veronica Arora for their talks. I would like to thank our expert, Dr. Chaitanya Shimbekar sir, for his expert comments for the debate, and of course the debaters which went on so very good, Dr. Akriti Gupta and Dr. Yuvraj Jadeja. The panel was the hit, I would say. It was a wonderful discussion that happened between the moderators and the panelists. Dr. Aditi and Dr. Amrita have done a wonderful job, and this new trend of moderators being youngsters and seniors being the panelists was a brilliant brainchild of Dr. Niharika. I would like to thank the panelists, Dr. Charmila Evu, Dr. Kalpana, Dr. Ritupanna, Dr. Sulba Arora ma'am, Dr. Rajul Tyagi ma'am, Dr. Ruchika Gar, and Dr. Himanshu Rai for being here with us. Special thanks to the MOC, Dr. Bhavini Shah, Dr. Ashwini, and Dr. Monisha for coordinating the session so very well. And I would also like to thank Team Samarth, Shield Connect, for giving us this platform to organize this wonderful program. Thank you so much, all of you. And it was a pleasure having you all with us. And I'm very sure we'll again join in some other YTP committee program with a lot more updates. The other committees, Siliguri's OBGYN Society and the West UP Society and the Agra Society, thanks for lending us, the society are helping us to join along with you all during this excellent program. I would also like to thank the ICOG team of Dr. Uday Tanawala and Dr. Ashok Kumar for granting us the 2